Bismillah ar-Rahman ar-Rahim. Today we have a panel on bladder exstrophy. We welcome our guests, Mr. Peter Cacao, Great Ormond Street, London, and Mr. Ramnath Subramanian, Leeds, and also Professor Osama Nagar, Ain Shams University, and Dr. Assam Al-Halabi, Tanta University, and everybody else. Okay, so we start with a keynote by Dr. Peter Cacao. Dr. or Mr.?
I'll answer to anything.
Unfortunately, I have a very short program. I don't know the title. Sorry. It's Bladder Exstrophy keynote.
Yeah, you'll see it.
Is that okay? Peter.
First slide, please. Thank you. It's a great honor to come to Egypt again. I love your country. I love the chaos of it, the busyness of it, and the history. But it's great to be part of a new part of your history, which is obviously the foundation and the first 2 years of your specialist hospital, which I am very pleased to be able to support by coming to your meeting. I'm going to tell you a little bit about my experience of bladder exstrophy. I'd like to tell you about other people's experience, but I didn't share it with them. This is an experience I've had over the last 25 years treating bladder exstrophy patients at Great Ormond Street. I'm going to share with you the opportunities that presented themselves to me and the results of the treatment that I chose. Next slide, please. So bladder exstrophy, 1 in 30,000 live births, 2-to-1 males to females. To some of us, quite a familiar anomaly, but a dramatic thing to see at birth, with the bladder on the outside, a separated pubic symphysis, an open pelvic ring, and in the middle, between the open ends of the pubic rami and the umbilicus above, sits the bladder. Beneath this, the genitalia are open. The clitoris is either bifid or the penis is open on its dorsal surface. And so this comprised really a urological issue, notably the problems of the penis and continence and the genitalia in females. Next slide, please. This slide is really not to teach you any basic embryology. It's just really to emphasize what the priority is with bladder exstrophy. And the bladder exstrophy is actually an abdominal wall defect. And I think as pediatric surgeons and pediatric urologists, we probably understand it better if we regard it as that primary lesion. Because if you can get the abdominal wall closed in bladder exstrophy successfully, then you've got half a chance of doing something good for the patient. On the other side, if you don't get the abdominal wall closed, or it dehisces, or it doesn't heal, then you've got perpetual issues, and the patient will struggle. Most patients in the United Kingdom, and I think it's interesting to discuss this with you guys, particularly in the context of other topics that we'll be talking about, like cloaca and in particular myelomeningocele, how good the antenatal services are in Egypt at diagnosing major anomalies before birth, because it gives us options. At the moment, there's no prenatal option for bladder exstrophy other than maybe a decision about the pregnancy itself and whether to terminate it. But we are increasingly seeing more than 50% of patients diagnosed prenatally through our screening program. Next slide, please. When I started in 1998, I have to say that there was 2 stories about bladder exstrophy. There's the enthusiasts who said that they made 70% plus of their patients continent. And then there was the realists and the people that I work for who tried very hard to emulate these results but failed convincingly. And this number of 80% continence is still close to that on the Johns Hopkins website. They say that 70% of their patients are made continent, but we need to understand what they mean by that. Whether it's people like you and me peeing in the toilet, which is what I think continence is, maybe that's slightly arrogant interpretation, maybe it's slightly discriminatory interpretation, but everyone in this room is continent. I haven't seen any puddles on the floor. You will go to the toilet at a time of your choosing, depending on how many coffees you've drunk. and whether you get the opportunity to go. And in the meantime, you're in clean, dry, sweet-smelling clothes. I've not got close to many of you yet, but I'm sure that's the case. Well, in most bladder exstrophy patients, it's not the case. And it wasn't the case for our patients at Great Ormond Street. Far from it. Most of them required an ileocystoplasty, a metrophenol, and a bladder reconstruction to become dry, to be able to contain their urine and empty it at their own will. They needed to use a catheter the whole time. And that was 80 to 90% of our patients. Only a very few of them were able to void. So there was a disparity of experience between the hyperbolic American experience reported to us and persecuting every surgeon in the world by overwhelmingly good results, which no one could emulate, and then the realists amongst us, and amongst those people, my very good friend and mentor, Philip Ransley, who'd failed to achieve anything like those results. Next slide, please. So if you've got disappointing results, you've got to look to yourself and think, well, why is that? And there's only two reasons that that could be. It's either the wrong operation, you're doing the wrong thing, or you're no good at it, or it's the wrong surgeon. And there's only two possibilities. So if you're a dedicated surgeon who's technically good, and you're working hard to try and achieve something, and this operation doesn't work, it's the wrong operation. So you have to be prepared to change. And this was my opportunity. Next one, please. So my boss, Philip, said, well, show me a male exstrophy that's dry, sweet-smelling, and potent. In other words, that has had a bladder and outlet reconstructed so he's continent and has a penis that is sexually viable and has testicles and that are fertile. And this was really a reflection of his experience, both through his own practice and those patients that he saw when he traveled around the world, that there was a lot of really bad outcomes with bladder exstrophy. And he challenged us to do something better. Next slide, please. Well, the coincidence of my employment at Great Ormond Street was that other colleagues weren't very interested in bladder exstrophy. They weren't enthusiastic about it because it was a grim diagnosis for most patients. Also, that the country in a whole was a bit disillusioned with bladder exstrophy and recognized that in small centers dealing with 1 or 2 cases a year, there was no scope to improve or study the patients. And so they decided to formalize what was being done already, which was referring patients to large centers, and those 2 centers in the UK were chosen to be Great Ormond Street, treating about 2/3 of the patients, and Manchester Children's Hospital, treating about 1/3 to 1/2 of the patients now. And so we went from 30 pediatric urologists doing occasional cases to actually 4 pediatric urologists doing rather more. Next slide, please. The benefit of that, of course, on the end of that slide was that actually this enabled us to group the patients into established services over and above those that we provide surgically, i.e. psychology, nurse specialist support, and urodynamic support, and various equipment and other things that could be purchased to look after these patients who were centrally funded by the government. Well, another thing that happened, which was a great opportunity, God rest his soul, Justin Kelly, in the latter part of his career did a sabbatical in London when one of my colleagues went off to learn about stone surgery. He came to Great Ormond Street to do his locum for 6 months. And that provided an opportunity for him to show me his different operation. And the rest is history. He showed me his procedure, which in his view showed that bladder exstrophy, you've got all the right things there. There's not much hypoplasia in bladder exstrophy, maybe the pubic ring, but the neurology is fine, the muscles are there, the basic structures are there, they're just not in the right place. And if you put it all in the right place, then it does have the potential that you'll regain the physiology that's been lost by the lesion. So that was his principle, and he showed me his process, which was to close the bladder at birth and then to perform a second operation later for continence, repair of the epispadias, and latterly I've added an umbilicoplasty to that operation. Next slide, please. So this is a primary closure, a reasonably straightforward operation, remembering that actually it's an abdominal wall defect, so we're really focusing on getting the abdominal wall closed without tension. And you can achieve this without osteotomies in the newborn period, which we did. My process now is if I see a patient with bladder exstrophy that's born, I often prenatally counsel them. They'll come and see us, and we'll talk about the bladder exstrophy. And then when the baby's born, they'll come to the hospital, and then we send them home. We send them home without the bladder exstrophy being closed. There are many reasons for this, but first of all, the patient's parents need to know that bladder exstrophy is nothing to be scared of. It is a pretty scary thing, but it doesn't kill you, and it won't do any harm to the child. It's the surgery actually that does the harm. Of course, there's no continence, everything's on the outside, but it's very survivable. And by sending the patient home, rather than taking the patient away, whisking them away, doing a surgery and putting everything back inside, you give the patient's family an idea of the severity of the abnormality, and this enables them to deal with it very well. And it sets their expectations. When they see the bladder's on the outside and there's no continence because the urine's just coming to the surface of the bladder, they don't have big expectations of what your surgery will achieve. And that's almost the right way round, because we need the family to be part of our team when we tackle these patients. Okay, so we can see the primary closure, we can see the result of primary closure. Next slide, please. This is just to say that osteotomies are not necessary. If you want to achieve continence, it's not bones that create continence, it's soft tissues. And if you allow the soft tissues to come together and grasp the structures in the middle of the pelvis, i.e. the urethra and the bladder neck, then they can actually act upon those structures to create resistance, and continence can follow. You don't need to move the bones. And actually, interestingly, look at the external fixation, which was used at Great Ormond Street for a while before this project. It's pretty difficult to manage a baby with that device on for 6 weeks. And the patient on the right actually is a teenager who had osteotomies at birth, but the pelvis seems to drift apart, so it's often not a permanent solution to the pelvic ring reconstruction. Next slide, please. So these are our results on primary closure, and it's just to show that we studied the results of doing a primary closure with nothing but epidural analgesia, coming back to the ward after the primary closure had simply been done, feeding the baby straight away and achieving early discharge in up to a week after the operation. The idea of waiting for 2 weeks is not just to familiarize the family with the patient and with the bladder exstrophy lesion, but it's also to make sure that the patient is in a positive nitrogen balance and well nourished. And of course, this is what pediatric surgeons know and urologists don't know, is that the most important thing in pediatric surgery actually is probably not surgery. It's nutrition, isn't it? And a lot of the conditions that we treat impact nutrition, and all the surgeries that we perform in the neonatal period are positively impacted by poor nutrition, which leads to poor healing. So a lot of the dehiscence is due to rushing ahead with a poorly nourished baby, stopping them from eating in the early part of their lives because they've had major surgery, and the rest follows, dehiscence and disaster. So we like them to be well nourished, and it works out pretty well. These are amongst the lowest dehiscence rates reported in the literature, even including those from Baltimore, where they do osteotomies and keep the patient in traction for 6 weeks. These patients stay in hospital for one week or 2 weeks after their surgery. Next slide, please. So the Kelly operation is a secondary operation, 12 months, about 12 months postnatally. After the successful bladder closure. It comprises, importantly, a bilateral ureteric reimplantation because all patients with bladder exstrophy have reflux. It also comprises a full mobilization of the soft tissues, including the urethra, penile corpora, and the pelvic floor. And the diagram is taken from Last's anatomy, and it shows in a slightly diagrammatic way, because it's not particularly anatomically accurate, how you need to lift the pelvic floor, because underneath this there's Alcock's canal, and within that is a pudendal pedicle, and that runs into the base of the penile corpus. And if you're going to separate that from the pubic bone, you have to mobilize the whole of its neurovascular bundle, otherwise you damage it. And so there's quite a lot of dissection, lifting the pelvic floor, finding Alcock's canal, and mobilizing it in order to mobilize the penis. Once you've done all that mobilization, you can do an anatomical reconstruction of the bladder outlet, the urethra, the sphincter, the bladder neck, and then the penis. And an umbilical reconstruction at the end is part of this procedure. Next slide, please. So here's a picture of the bladder being opened. If anyone's got control of that noise, if they could turn it off, I'd be most grateful. Thank you very much. Maybe it's outside. Okay. And you can see the bladder's opened here, bilateral Cohen ureteric reimplantations, and then a reconstruction of the bladder neck and the urethra, having lifted it off the back of the corporal bodies and delivering it beneath them and between them, where it can gain a relationship with the structures between the corpora, which comprise the perineal muscles. Next slide, please. This is showing from below. If you sat below a patient with bladder exstrophy doing a cystoscopy, you literally see this aspect of the penis. Obviously, the skin's taken away, but the corpora have to come across to the midline in order to unite below the glands of the penis, and they form a V-shaped penis. Geometrically, if you divide that from the pelvic sidewalls and bring the base together, you attain more length, and you also attain a cylindrical penis. And in the same time, you can bring those loosened muscles between the base of the corpora around the reconstructed urethra in a hyperspadiac position, and that's what this shows. On the right, you can see the vessels running into the base of the penile corpus, which is the mobilized, medialized pudendal pedicle from a freed up Alcock's canal. Next slide, please. So this is the Kelly operation. In the top left, you see the three pictures, the before and the after, and the healed penis. And you notice the dramatic change in the penis that the Kelly operation achieves. And this is, you will say, a selected slide, but it's a typical appearance following this radical mobilization. On the right is a female equivalent showing the umbilical reconstruction that's also done by folding up the scar tissue from the primary closure in a spiral and sinking it in the midline, about 40% of the way between the pubis and the xiphisternum. On the bottom, we can see that if you make a hyperspadis, you need to actually recreate the urethra, and we do that in a two-stage technique, analogous to hyperspadis, which I believe you discussed yesterday. Next slide, please. This is the female situation, and just to say it's very similar, except the emphasis is slightly different because those muscles extend between the base of the clitoris, which is very importantly mobilized as well. And the urethra, which is, rather than being above all of this, is actually anterior to it, is actually encapsulated then within those muscles when the clitoris is brought around and in front of it, and those muscles gain a relationship to it and the bladder neck above. Next slide, please. If you're going to do something for continence, you've got to know what you're talking about, and people have got to understand what you're trying to achieve. And so I developed this grading system for continence, which is really very simple. If you've got bladder exstrophy, the bladder's on the outside, and often after you've closed the bladder exstrophy, it just dribbles out. You're walking around as a toddler, maybe, and urine is just running down your legs or dripping on the floor. There is absolutely no control. So that's zero continence. If you're able to hold on to it, of course, you can walk around and not leave a trail of drips, and maybe you have what we call a dry interval, but maybe it's not long enough by virtue of your bladder capacity not being big enough, or you not having learnt the finer points of control yet, that you still need to bear protection, and you're not continent, but you have the emerging shoots of success, shall we say, and that you can hold on for even a small amount of time. Grade 2 is more than that. When you've got better bladder capacity, you've learned a little bit about the sensory feedback of your bladder being full, and your ability to void in the toilet enables you with sufficiently good bladder capacity to be dry in the daytime. And this is level 2, and level 3 is when that extends and the bladder capacity is sufficient for you to be dry at night. Level 3A is an alternative pathway where you do an augmentation cystoplasty because your continence procedure from the Kelly operation has not succeeded. And that cystoplasty, which was the old tried and tested technique of making patients continent with bladder exstrophy, and we may even do a case tomorrow, is what patients have if this Kelly operation doesn't work, and that's always been the case, and it is successfully achieved even after a Kelly operation. Next slide, please. So Over the last 25 years, I've taken a cohort of consecutive patients, no selection, every patient given the same chance, no measurement of bladder capacity, no measurement of bladder plate size, no stipulation that they had to have a completely successful primary closure before we did the Kelly operation. Every single patient in sequence had a Kelly operation. Now, I didn't treat all the patients, and certainly in recent years I haven't treated all the patients, and so the series is not as big as it might have been. But there's well over 100 patients that have been studied and have had this operation done in the same way over the years. The primary assessment, or the assessment, was performed by a clinical nurse specialist, and any urinary tract infections were investigated with ultrasound scans on a regular basis, but also a DMSA scan to look for renal scarring. And latterly, we performed urodynamics, which we started to do in every patient, but we've performed more selectively because of occasional complications with the catheter placement that dampened our enthusiasm for it. But I'll show you the result of a study later. So outcome measures that we chose in the United Kingdom were success of primary closure, continence development, renal outcomes, and then the genital outcomes, which I'll look at in sequence. Next slide, please. So early on, we got an encouraging outcome. And if you look at the bottom line, over 2 years from the Kelly operation, there were 24 patients. Most of them had a dry interval. 2/3 of them were actually dry in the daytime, and about 1/3 of those were also dry at night. So we were achieving nighttime continence and daytime continence in 25% of patients 2 years out from the Kelly operation. So it encouraged us to see what happened and also to continue doing it. Next slide, please. So why do patients develop continence? This is a generic slide. It's not specific to bladder exstrophy, but it does illustrate the sort of cycle of continence development. First of all, there needs to be outlet resistance. Urine production fills the bladder. With outlet resistance, it fills it more, particularly if the bladder is compliant. And in those ways, the bladder develops capacity. Obviously, if the child has a lot of urine output, is drinking a lot, the capacity needs to be greater, or the voiding needs to be more frequent to maintain continence. And one of the ways that children maintain continence in the daytime soon after Kelly operation is actually to reduce the amount they drink and to void more frequently, which they can't continue during the night, which is why a lot of them attain daytime continence a long time before nighttime continence will follow. Next slide, please. So this is just to show capacity versus continence in the early experience, that actually as you got up to beyond 50% of your expected bladder capacity, calculated by a simple formula of your age plus 1 times 30 mils. Once you get up to 50% of that expected capacity as your actual capacity, then you start to become dry during the daytime. Next slide, please. So we wanted to look at the muscle physiology because we wanted to understand this theory that everything is actually normal, but just not in the right place. What was the lesion of bladder exstrophy? Was it a muscular lesion? Was it a neuromuscular lesion? Was it another kind of lesion? And so we took muscle strips from early cases of bladder exstrophy and looked at them in an organ bath. And we tested them for nerve-mediated contraction and then direct stimulation of the muscle with chemicals and to see what the responses were. Next slide, please. And we can see, if you look at a normal control patient, such as a patient having a ureteric reimplantation or rhabdomyosarcoma, where a little bit of the normal bladder was also excised, you can see the force frequency response is brisk. In an exstrophy patient, at the time of their Kelly operation, it is reduced, but it's significantly less in the neonatal exstrophy. And they suggested that the neonatal exstrophy following primary closure, those muscles improve as per this graph. And you can see cloacal exstrophy is in yellow, you can't really see it, but the results for those bladders is really awful. Next slide, please. Is it a muscle problem? We took a single cell. You can tease a single cell out and you can put it in an organ bath and you can stimulate it with calcium and other chemicals and solutions to see it contract. And when you do that for any muscle cell out of any of these bladders, primary bladder exstrophy, secondary exstrophy at the time of Kelly operation, normal control patients, or cloacal exstrophy, those muscle cells are all the same. So the muscle cells are the same, guys. and they have the potential to work. So what's stopping them from working? Next slide, please. This, the matrix. When we look at the matrix, we see, as in the here, when we look at the elastic work, how much work it takes to stretch it, which is, if you can think of the connective tissue of the bladder like elastic bands. And in the bad bladders with a lot of matrix, we now know that they're very stiff and very difficult to stretch, like loads of elastic bands, whereas the healthy bladders stretch really easily. And of course, that's the wonderful property of our bladders, that it can go from nil capacity to 500 mil capacity, and it stretches so beautifully without increasing its internal pressure. And that's what's lost, and it's the matrix that's the difference. But between the neonatal and the primary patient who's having a Kelly operation, there is healing, and so the sequence of primary closure and then the Kelly operation seems logical to achieve a better bladder at the time that you challenge it with a better outlet resistance. Next slide, please. Next. This is a urodynamic study. If you waggle around your cursor, you might be able to turn it on. But if you can't, don't worry, because on the left you can see the normal urodynamic tracing. This is a normal contraction. The video would show you that it empties to completion through that urethra. The urethra is slightly off horizontal, or off vertical. Normal male urethra is quite vertical, and this is a bladder exstrophy urethra clearly because it's tilted forward. Next slide, please. And this is a video looking at the bladder outlet in a reconstructed bladder X-ray, showing that typical opening in front of the jet from the cystoscope that we see in a normal cystoscopy. Next slide, please. So just going to show you 93 patients that we looked at in 2014. Next slide, please. The feature of this is they're male, female, and revision cases. So we just look at the bottom right segment, or to the right segment of 5 years and 10 years of these 46 males, we can see a preponderance of stage 2 and 3 continence in those patients, and a few patients who've been augmented. Next slide, please. These are the female cases, biased a little bit out 10 years because 2 of them were augmented early on. For poorly compliant bladders and dilated upper tracts, but we can still see a preponderance of day and nighttime continence. Next slide, please. Interestingly, these were patients who had a previous bladder neck procedure or a prior epispadis repair before their Kelly operation, so were classified as redos, and a lot of these patients came up out of the woodwork in the early stages, and a lot of these patients as well, at 5 years, you can see a large proportion of those, all of them that weren't actually augmented, became continent. Next slide, please. This is the summary. 81% male cases dry in the daytime, half of those dry at night. 13% augmented female cases, 2/3 dry by day, 1/3 dry at night, and 1/3 augmented. Salvage cases, both male and female, 80% dry by day. So there's hope even for those who've had a prior procedure. Next slide, please. So the renal outcomes, this is just to say a few patients got renal scarring. One patient actually has renal impairment and is on supplements, but is not yet on replacement therapy or dialysis. 2 of the patients who actually got bad kidneys also had bad bladders and required augmentation. And so it's worth looking out for those patients who don't develop continence or develop compliance in their bladder, because that non-compliant bladder is dangerous for those kidneys. Next slide, please. The penis is always bad in bladder X-ray. People say that the penis is always bad, but what are the length limiters for a penis in a bladder X-ray reconstruction? This is not a typical photograph of a patient actually who subsequently did have a Kelly operation and had a changed appearance, which I'll show you in a minute. But if the penis is held apart by the diastasis, that limits its length. The urethral plate is often very short, and that limits its length. When you do an osteotomy and internally rotate the penile base, then it pulls the penis in, and that osteotomy picture will reflect that, and that's what happens. And in addition, dorsal chordae holds the penis tightly against the anterior abdominal wall, and all of these things are addressed in the Kelly operation, need to be, to not limit the penile length. Next slide, please. Complications overall tend to happen after the primary closure. This is why it's got to be focused on as the primary focus of bladder exstrophy, not the bladder in that first instance. Get a good closure of the abdominal wall and all other things are possible. So about, what you've seen from the series I presented earlier, but between 2000 and 2015, 8% of patients required surgery for a partial dehiscence or a dilatation of a tight outlet, leading to CAICC. Previous slide, please. Can we go back? Yes, thank you. And a lot of patients had urinary tract infections, which is reflected on the number of those that got scarred. But of course, if you've done a ureteric reimplantation, you can separate the upper from the lower tracts and mitigate the otherwise universal reflux that patients have and the universal scarring that they will develop if you obstruct their outlets and they get infections. Next slide, please. So these are some of the long-term issues. You can see the reconstructed umbilicus looks quite natural, as do the genitalia. Next slide, please. And these are a group of outcomes or warts and all type set of pictures. Next slide, please. I wish I could show you the same for the patients who were treated prior to the Kelly operation, because the penile outcome in particular is quite different. Penile outcomes are good. I was worried about erections until a patient showed me an erection in the clinic, and the patients who are now teenagers and young adults all have erections. Cordy is a difficult thing to repair by external rotation of the corpora and sometimes need to be readdressed after puberty, and the urethral reconstruction is not perfect if you have to do a hypospadias repair with an extragenital skin graft. But we've not lost a penis or any glandular tissue. Next slide, please. This is the summary continence results that I presented. This is the summary of the 25 years presented at the SPU in April, and the minimum follow-up was 5 years after Kelly operation. There was over 100 patients. And if you look at the bottom right, you can see that large numbers who are continent stage 3, more than 15 years out, nearly 90%. So it works, and if you're one of those 90%, you have a transformed life. Next slide, please. There's a lot of bad outcomes out there. One of the reasons that one travels is that you get asked to treat bladder exstrophy patients, and it's a difficult thing to treat, and I'm not pretending that it isn't, unless you have a systematic approach in a centre that's used to doing it and a surgeon who's familiar with it. You can have bad results, and some of these results are shown, except these aren't all from non-specialist centres. At least 2 of them are from major American centres who required redo surgery. Next slide, please. What are bad outcomes due to? Let's be honest about this. In the same way as if your outcome is poor, it's either the wrong surgeon or the wrong operation. We can be a bit more specific about that thought. First of all, a lot of surgery is done by many surgeons, some of whom have never treated bladder exstrophy or treat very few bladder exstrophies in their careers, and come from centres where not many are treated, and it's not a familiar diagnosis. There's very few specialist centres where patients are grouped in large numbers, and that probably needs to change, and I think your hospital has great hope of developing that. Its whole mission statement must be to address that particular issue. There's very little honest accountability or established outcome measures to enable comparisons. There's a lot of smoke and mirrors, and you may even regard some of my results that I presented as being just part of that. I hope not. But there's no unified approach to assessing their outcomes. Surgeons are very proud. They always like to think that they can do a bit of everything, although in the UK, that pride has been swallowed, and patients are given to specialist centres, and it's not the enthusiasm of the specialist centre that creates the success. It's the donative involvement of other surgeons in the country that pass the patients to that specialist centre. So your centre, your fantastic specialist hospital, will only thrive if other surgeons in Egypt send you patients. Otherwise, they could just treat them themselves. So politics and finance is a very big part of it. Next slide, please. We're nearly finished. If you take the United States as an example, because we all like to dig at the Americans, don't we? But if you take the United States as an example of what happens in bladder exstrophy, there are lots of bladder exstrophy patients, 122 cases a year, and there's 0.12 bladder exstrophies to every academic medical center in the United States. And really, there's 0.17 cases to every pediatric urologist. So if they all do bladder exstrophy, then there's not going to be much experience for any of those. So the way that we could bring things forward is to create major centers with a bigger experience and invest time in those centers and the surgeons in them to develop greater expertise. Next slide, please. The Kelly operation can, just to show you, create a transformed outcome. Look for this penis and the result after his Kelly operation, bringing it together in the midline in a more recognizable form. Next slide, please. This is a modern stage repair on the left that was performed in another country, and you can see the results of his reoperation, and the Mitchell repair on the right, the result of his Kelly operation. Next slide, please. Penile salvage surgery is also a focus of the surgery in patients for whom maybe continence has been fixed or dryness has been achieved with an ileocystoplasty. Sometimes the redo surgery is simply to create a more recognizable penis. Next slide, please. So, just in summary, this is my experience. This is what I've been doing for 25 years, I suppose. But I believe this Kelly operation can achieve void incontinence, which is a game changer. The complication rate can be quite low, but you have to be careful. It's big surgery. It has to be done diligently and carefully. It could be beneficial as a secondary procedure, even if patients who've started on another pathway. The genitalia is significantly better, but not perfect, and remains a big challenge in bladder exstrophy surgery. But I would really push hard in any country that fewer surgeons and fewer centers specialize in high volume treatment of these cases, because certainly this is what benefited our patients in the UK. Thank you very much.
Thank you, Peter, for your keynote. Quite informative. Any questions from the floor?
I want to ask a question.
Sure.
So, Peter, you said about the closure in the neonates, and that's what you do as early as possible, right? So about 2 or 3 days, or anyway, as early as possible. And you said without osteotomy, is that the same case? Because when I travel at different places and you see cases in 3 and 4 years of age of primary extreme not closed, and without osteotomies, would that be a challenge, or you think osteotomy doesn't make a difference?
I think you need to use osteotomies. Obviously, what we've done here, what I've done is to look at the primary case to see what happens if you treat bladder exstrophy according to a certain protocol. This is the one I've shown you today, where you have control over what you do, and the primary closure is done at around 2 weeks of age when the child is on a positive growth spurt, having been at home with the family for that time. And no osteotomies are required. In fact, up to about 5 months of age, I've closed bladder exstrophy in a neonate or a young baby without the use of osteotomies. Where osteotomies do have a place, and a very important one, is in every case of cloacal exstrophy, because tagged on to this experience were about 40 cases of cloacal exstrophy that I've treated. That's mandatory because the diastasis is 6 or 7 centimeters often, and you can't get the abdominal wall closed without osteotomies. Also in the redo cases, and in the older children that maybe haven't been operated, I think they're also important. But it's not a primary treatment as many are advocating. It's simply to release the tension in the midline, get the abdominal wall together and get it to heal without tension.
Dr. Saber?
Thank you, Dr. Peter, for this very nice presentation. My questions for the cases which postponed, which is not indicated to be operated at the time, delayed for the delayed repair. Is there a rate for the growth of the bladder to for the proper time to operate, or only just after 1 year, at the age of 1 year? What is the rate of the growth of the bladder? How to assess?
Well, thank you. Thank you for your question, because it enables me to emphasize what the difference is. I've seen patients. I operated in a Middle Eastern country recently on a patient that was treated in Johns Hopkins Hospital, And his family had been told, because the child didn't reach the target bladder capacity, that the bladder neck reconstruction could not be done. And I think that capacity was measured at about 90 mils.
Okay.
So I've never measured the bladder capacity other than for information, never as a modality which would decide what surgery that I did. I thought it was a bit, when my child was 4 years of age, she went to a test at her school. The school that we wanted her to go to, she went to a test. And she had to stack bricks and do other things. If she failed that test, she was denied a place at that school. I thought that was so unfair that we would deny a child a chance in life on the basis of a single test. And I absolutely have always felt that. So when I heard in Baltimore they were denying the child a chance for their continence operation just because they didn't fulfill a certain capacity, then I just thought that was wrong. And actually, because of that was a dogma, having abandoned it and treated every single patient, regardless of bladder capacity, I found patients initially who started with 20 or 30 mils capacity that have become continent, with a capacity of up to 300 cc's 5 years later. And the index case actually is a nurse nowadays, but when she came, she was a 9-year-old and had a bladder capacity that I measured at the end of her Kelly operation of 20 cc's. But she was dry by day within a year. So I think that we create these artificial dogmas and barriers and maybe deprive patients of an operation as a result. So I disagree with that policy that's used elsewhere. There is an opportunity in that though, because increasingly I'm seeing patients who've been rejected by that centre and who are not being offered a continence procedure. They're being offered a cystoplasty and a metrophenol, which is the unspoken large group of patients of that particular practice. And those patients do quite well after Kelly operation. I did 2 last month. And I think it's going to be a growth area because the results for the redos are quite good.
Yes, okay. I have a second question, please. Is there a definite rule about the type of pelvis? You know that there is a different types of pelvis. The pelvis of the child, the bony pelvis, and the space between the symphysis pubis, how it is wide, can affect the Kelly repair? Okay, how can affect?
I mean, again, I think if it's a classic bladder
We know that pelvis tilted downwards, tilted upwards, widely separated.
Well, I think when you talk about different pelvic morphology and bladder exstrophy, often what you see is as a result of having had osteotomies, that when you do the osteotomies, there is rotation, as well as pardon?
I didn't do osteotomy.
I know. I'm not saying you, but I'm saying if one was to do osteotomies, then we don't get a perfect hinging of the pelvis and coming together in the midline. We get it twisting and turning, and we've all seen the deformities that can result from osteotomy as well.
My question is how affects the tissue repair, the soft tissue repair? Prognostic.
If you do an osteotomy,
when it is prognostic, good prognostic, and when it is.
I don't think. Well, let me just. It might answer your question if I explain it like this. If your arms are touching the side of the door, you cannot hug your child because your arms are apart. You have to let go of the door before you can wrap your child in your arms. And in the same way, when you do a Kelly operation, you cannot wrap the bladder neck or the urethra until you separate or let go of the structures that hold it apart. So when you separate the soft tissues from the diastasis, only then can they come together in the midline and grasp the structures that they need to create the variable outlet resistance that you want for continence. So that's the principle of it, and it works. Whereas if you try and move the bones, just to let it come apart again, then that muscle can never let go and envelop the bladder outlet as it could potentially do if you let it go.
Ask about how you do sometimes a release incisions bilateral in the external plane.
To get the abdominal wall closed in the midline?
Yes.
No. But what you're not bringing together, when you bring together bladder exstrophy, you have to be careful that you define the bladder plate and the proximal urethra and bladder neck area, and that you keep enough in the midline to provide a closure whilst leaving enough on either side to be able to come together in front of it. So what you're bringing together in the midline is not the actual bone or the cartilage, you're bringing the soft tissue medial to it together. So there'll still be a diastasis where you've got the closure. But if you cut very far laterally, I think it's like two-stage hypospadias, if I might say. In two-stage hypospadias, you've got a nice skin graft on the undersurface of the penis. You need to take just enough to make a nice urethra. If you make a really wide urethra, then you don't have enough skin to go around the outside, and it all comes apart, doesn't it? So it's the same sort of principle. You've got to balance the two priorities, and if you prioritize the abdominal wall rather than the bladder, because most urologists would prioritize the bladder, then you'll have more success in the primary closure.
Dr. Kako, see, I have a question, but I'm the moderator, so I'll keep that to the panel. Next talk is Dr. Subramaniam from Leeds. He's going to give us a different perspective on bladder exstrophy repair. Thank you.
Can I have some slides, please? Thank you. Before I start, I just want to make an absolute straight confession is that I'm not an expert on exstrophy, so I'm really glad Peter is here. Otherwise, when they asked me to sit on the panel, I was thinking, oh my God, what am I going to do? However, this has actually provided me a fantastic opportunity as a surgeon who has been best part of 25 years now through my training, as well as working as a consultant for the last 20 years in Leeds, to observe what Peter has alluded to the ideal model of where one should restrict the work to certain centers. But then equally, I have had the opportunity over the last 5 or 6 years, and as I'm growing and getting older and people ask me to travel, particularly to low-income countries in Africa, where I'm very proud to support a charity work, that I get asked to see patients with exstrophy and epispadias and asked to try and what I should do, and I say, well, actually, I don't know what I should do because I've never done one, but I've observed, and I want to put a perspective on this whole scene of what I would consider as a low volume, high burden, relatively poor outcome, unless it's in expert hands like Peter. And to give Peter the due credit, he taught me a lot of things, including what I said yesterday, and I'm glad he's here today. I can repeat it to say thank you very much for showing me how to do an hypospadias repair, which I can consistently do for 15 years. So you are a fantastic teacher. And all of you will enjoy his experience, his operating in the next couple of days, because I have enjoyed it thoroughly when he had taught me things. So make the most of it when he is here. But I just want to present to you a few slides because I have watched this now from a global perspective, and the reality is starkly very different when we look at providing this service for a larger number of patients rather than a selected few in privileged centers. But I wanted to just give a shout out to my colleagues in Manchester, who are just 15 miles down the road from me towards the west, where the second bladder exstrophy center in the UK is. And I'm absolutely glad, although when I was starting as a pediatric urologist in Leeds, which was after 2000, I was quite disappointed that I would not be part of that program, and I was a bit upset. But my colleague David Thomas wouldn't really fight for it, but he was the wise man because he sent it all the way to 2 centers, and I am very happy to have been part of that program because I recognize that it needs to be within centers of excellence like Peter has alluded to. So this is the second center. So again, these are not my slides. Couple slides I borrowed from David Keane, who was my fellow in urology, and we very, very closely worked together, and his senior colleague, Max Sevillon. So this is the second center. So as Peter said, 2000, there was a 2-center nationally commissioned service. Next slide, please. So on the previous slide, there was David and Max. Max was a shorter one, Italian. with a nice Mediterranean flavor to it, so I won't say any more. After that, this is the bladder exstrophy as we divide into two regions in England. This is the north of England and south of England, and as Peter alluded to, the one in dotted lines probably work in the Great Ormond Street area, and the other ones go to Manchester, although it's not strictly divided that way because centers can choose where they want to go to, but effectively they do about 10 to 15 cases a year. That's what both the centers claim. Next slide, please. So they do a different approach. They do the staged repair, and that's what David sent me. And in contrast to what Peter was suggesting, they do the bladder closure fairly around 6 to 9 months of age. They do a epispadias, and if I remember correct, they do osteotomies and leave the child in frames and stuff for 6 weeks. So I'm not entirely sure about that, but I think that's correct. And then there is potty training, and then they do continence surgery later. And anyway, it's a different approach, or the delayed staged approach. And as you can imagine, it spreads to about 17, 18 years by the time everything is completed. And it's a long drawn effort. And behind the scenes, as Peter has alluded to, it's not just about, well, I agree with Peter, and to some extent that it's either a wrong operation or the wrong surgeon. I think that a lot of it comes with the support services, and I think there is psychologists, there is physiotherapists, there is family support, nurses. There's an intensive amount of money and investment into two centers in the United Kingdom to be able to achieve what these two centers can do. The only sad thing about it is that we're not able to compare the approach for various reasons, but we won't go into that. But I wish we had a bit more approach to be able to compare and contrast both the centers. Then we would be able to see the unique advantage of comparing two types of repair, which at the moment sadly is lacking in terms of the data that's available for us to view. Next slide, please. So I wanted to show this picture because David Keane sent it to me, and it's fascinating because the various different types of polypoidal mucosa that you can get in a bladder, and as Peter has said, the bladder itself is actually normal and the muscle cells are normal, but because you don't do it over time and they are exposed outside, on the far end, on the C, is what vast majority of patients that I see when they come to low and middle income countries at later years of age, highly polypoidal mucosa, and they're not yielding. So it's not so easy to get a closure of the bladder closure, the simple closure that one would expect, without much other support services and the risk of breakdown. Next slide, please. Again, to give due respect to my colleagues in Manchester, they have 100 consequential patients, just like Peter has said, another 100 he's done, and there's a different approach, and they have what appears to me pretty decent success rates. So one would, when you observe from the outside, you probably would think that it really doesn't matter because both are the same reasonable approach for these patients. But like Peter has said, and I firmly believe in Peter's approach, is that are we talking about the same things in terms of continence, and how you define these things is something which is subject to controversy. Next slide, please. But I want to put a different view, because this is a paper by Catherine DeVries in Journal of Pediatric Urology, and she's got a slightly Americanized views of this whole system, but I just acknowledge and put things up there because it is tough out there. Patients often have to then buy a lot of things, fend for themselves, even suture materials. They don't have, and I have to carry a lot of suture materials with me, and if I don't take a stock, they won't have for the next few months to be able to operate. They really rely on the NHS to support some of them, and that's how it feels. And while Peter attributed some of the highlights of really good healing is nutrition, that age, and these poor children don't even get that, so that's a real issue here. Next slide, please. And then put into context a fairly high fertility rate and birth rate in Africa. So you can imagine a 1 in 30,000 condition. It's got a significant number of patients out in that population compared to what you would see in the Western world. And it is shocking to see the United States slides, which Peter suggested, that you get 0.5 cases per hospital center in the United States. Whereas here, there's a rich potential of work that's actually out there if somebody wanted to invest some time and experience and do something about it. But sadly, you don't have the resources. Next slide, please. To give in perspective, this is the electricity issues in one of these countries, less than 4 hours per day. And you can see where I'm talking about the green shaded areas. This is where low and middle income countries you're talking about, where there is a high density of patients with these conditions. Next slide, please. So I think in some ways this is correct. It's an evolving maldistribution. Sorry, I just copied and put things up there. But essentially what it's trying to tell you is that even in high income countries, That is a real difficulty with these conditions. But in the low-income countries, they have no chance, absolutely no chance of anything, for various reasons I've alluded to. Next slide, please. So then what did they do there? So I was shocked. I went to Tanzania and I was in a meeting, and the first day of my workshop, and I sat out there and they said to me, Prof, I want you to close, we would like you to show us a closure of bladder exstrophy. I said, oh, okay. And I said, okay. And they presented the case, and it was a beautiful looking bladder actually, a wonderful looking bladder. And I thought, this doesn't look like exstrophy to me. But nevertheless, they said to me that every exstrophy bladder they excise, they do a cystectomy essentially, and the ureters are diverted into the colon, and that it's a single operation. Okay, and at that time I was shocked, I have to say, 5 or 6 years ago when I started this journey. But over time I started understanding this. Where are you? What is the strategy based upon the context what we're talking about in these low volume, poor outcome, which I call the high burden disease because of significant resources necessary, both in terms of manpower as well as the spiraling cost of healthcare. So what is correct? What is correct for these group of patients? Because then I was in Malawi this year, and the surgeon said to me there, why is the point? Because the average life expectancy is 45, 50 years now, and at the end of the day, one operation, and we send it to Blantyre to get it done, and it's not a problem for us. And it actually made me think rationally, maybe it's not such a bad thing, because at the end of the day, they just can't afford to do any of these things with support services. Next slide, please. So there are attempts. Now I don't know what is correct, what is wrong, and I'm sure Peter he's also traveled a lot and he does support services outside. There are some collaborative and things coming in terms of mapping the resources, identifying trainees, having a strategy to help these children in those places, and is there some way we can do better? With everything that's going on there. So that's why I just wanted to put a twist, thinking about it, because I have been able to observe what's happened in the United Kingdom, what's happening outside in the well-developed Western world like the United States, and what's happening in low-income countries. So that's a perspective that I want to put outside for people to discuss.
Any questions?
Well, I'd just like to say that it's difficult to get people around a table to honestly discuss the outcomes. I tried to get the colleagues in Manchester over many years around the table to talk about outcome measures, and in fact we defined our national outcome measures, which are the ones I showed you. The success of primary closure, the development of continence. I set the standard of being dry in the daytime by the time they start their primary school, age 5 in the UK. And then the other thing which Manchester wanted to look at was renal function and damaged kidneys, and ultimately fertility and genital function. So those are all established as outcome measures, but we were unable to have a meeting with everyone around the table to suggest any way forward. Because the difficulty is, of course, if you present data and it's not as good as someone else's data, you have to address the reasons why. And you might be in a position where you feel you're a well-established centre, you've got everything organised, everything's going well. It's very difficult to step back from a standard that maybe you aspired to, which has become almost part of the folklore of your centre. I think that Johns Hopkins has a big problem with this, because their recent publications and presentations, challenged by me in the meetings, they admitted actually probably about 15% of all of their patients, every single patient coming to them, out of them, 15% of them has void incontinence. If you look at the website, it says 70%. So this is a big problem. Actually, it's a probity issue. It's a reputational issue. It's probity equals honesty equals candor. There's many issues with that, which I wouldn't want to face. But I think they have to. And there's a big reputational aspect of a big hospital with a big reputation. And I worked in one which has many issues about its reputation, maybe not in this particular group of patients, but with other groups of patients. So you have to be careful when you set up a flagship hospital that you maintain a self-critical honesty about what you do. The interesting thing about the data that you showed, which is the first time I've seen it actually from Manchester, is that 50% of their patients have a bladder closure and an augmentation cystoplasty, 50%. and I think I presented about 13%. So there's a big difference. Yeah, that's a big difference. And that's a comparator that's available. And, you know, if you believe the data on either side, and I suppose there's a requirement that maybe you do if you make these decisions, where would you send your child with bladder exstrophy? And so there we are. It's difficult. It's difficult. And, you know, the surgeon that says, I'm no good at severe hyperspadias, I'm going to give them all to my junior colleague, will actually create a massive difference for patients in his sphere of influence having severe hyperspadias operated on. This happened in Southampton Children's Hospital. There was there's a colleague that I trained similar to how I trained Ram actually, and I saw him last week, and he went to that hospital and 6 surgeons were doing hyperspadias, and all of them were doing 1 or 2 major cases a year. Within a year of him getting there, he was doing all of the major cases, and he achieved similar outcomes to the ones that we were able to achieve in London. And that really changed things for that whole practice, for all of those colleagues actually, who benefited from him being able to focus it. And it goes for any diagnosis in pediatric low volume, high impact diagnosis such as cloaca, such as myelomeningocele, such as severe anal rectal anomalies, such as massive exomphalos, even the rare cardiac defects. They all benefit from a few people doing lots. How do we create that? And do we wait for it to happen politically? I think every pediatric surgeon has within their grasp the ability to facilitate and be part of that.
Okay, thank you. Cool. Yes. Mike.
Okay, the question is for Mr. Ram or Mr. Peter and the dear panelists. I have a case, she 18-year-old female with a very bad outcome of bladder exstrophy. Till this moment, she has her bladder out. Okay, operated many times before, since birth, and with osteotomies were done twice, and the primary closure was done maybe 5 or 6 times, and 2 of these were done by figures, external visitors even. But the final result, she has this moment out. So is it right now to excise her bladder, to attach her ureters to the colon, or to keep her as she is, or to try more and more? Thank you.
Sorry, did you say the bladder is out?
It's out, yes, all the time.
Oh, it's exposed again. Exposed.
Yes, exposed.
Okay. So
She is wearing diaper all the time.
Okay.
Yes, thank you.
You guys have a change.
And she's augmented, Dr. Wright?
No, she is not.
She's not augmented up to now.
Yes. She has a good sized bladder, so someone.
Yeah. I think if it is all will depend on how much bladder plate still we have, this child still have. So the key is not only the size of the bladder plate, it's the quality of the bladder plate itself. Because I think if the bladder plate is become small and it becomes fibrotic, there is no sense of trying again and again to close it at this stage. We are increasing the suffering of the patient and disturbing psychology of the parents and the patient more and more. So I think this is a way to do some sort of augmentation and to end by CAICC. And we have to be very realistic in addressing a case like that. I have been in different African countries. I'm facing some of these patients coming very late, 18 years. Last case in Zambia a few days ago, she is at 18 years. And we have to be realistic in approaching these parents. So I think back to your case, I think there should be with some augmentation and then CAICC.
For the augmentation solution, I think her main problem is with the coverage itself, skin coverage. Okay, yes, she has very great dehiscence every time, and immediate dehiscence. Within 1 week, she has full dehiscence. They tried to do muscular flaps from here or there, all of them have failed. Yes.
I used to do something which may not be very much written in the literature, but I used to do mesh. After closure, I put mesh, and this is something a little bit maybe strange, but I think this is the way to go, to put some sort of artificial mesh and then closure the skin over the mesh. I have troubles with this mesh in some cases, but still they do not disrupt. And that's the bottom line. We have stitch sinus, we have sometimes to go to take it a piece by piece, but after not the first case, not the first operation, but at the end of the day, we have a closure of the abdominal wall with some complication of this mesh. And some of them, they don't have any problem with mesh at all.
Okay.
Very often, repeated failures are because there's no fundamental change in the approach. I can do better than that other surgeon is an oft-touted thing, isn't it? Oh, he's no good, I can do it better. And the same mistakes are made. For example, in a teenager, if you do big surgery in their abdomen, but you don't do good analgesia, then they strain against it. They've got lots of muscles pulling everything apart. So you need to have good analgesia with an epidural for 2 weeks, with a tunneled epidural. Repeated attempts, I mean, it depresses me. I think we see it much more often, don't we, with hyperspadias, where the same surgeon has 10 odd goes at fixing it. You know, I just want to cut their hands off. What are they thinking about? You got it wrong, it didn't work out. Just step back. Because using the same approach repeatedly destroys the abdominal wall. That's what's happened. There's a thin skin layer, and whatever you do, when you close it, it comes apart. You can't get muscle, you can't get decent fascia together. There is no fascia, it's been destroyed by the previous surgeon. So you're up against it. I think that in that situation, you have poor blood supply to the anterior abdominal wall, so a mesh will get infected and maybe even make a worse problem. So I won't pretend that I have an easy answer to that. But what I would do with a case like that, I would try and do something very different to what had been done before, creating a different environment in which it was going to be done, recruiting the help of others, plastic surgeons for rotational flaps from the thigh, for example. Gracilis and other muscles have good blood supplies and can be brought into the area to provide the closure, maybe in a staged sense. Considering excising the bladder and doing ureterosigmoidoscopies is one way of doing it. I've been against that because of the long-term risk in patients I hope will survive for 90 years of colorectal cancer, carcinoma within the bladder. And that's a real risk, and that was demonstrated by Christopher Woodhouse. The admixture of urine onto a fecal mucosa at that junction is a problem. The mixture of the feces and the urine is what's toxic. So I would try to avoid that. People have done that, a mites to pouch, which I suppose would be a way of trying to avoid that. I'm not sure if the long-term results of that aren't very similar actually to straightforward ureterosigmoidostomies. So my approach has been to try and get the abdominal wall closed and to do an ileocystoplasty, augmenting the bladder plate and using that also to implant the Mitrofanov into on the right-hand side. If it's a small plate, then you can move the ureters to the other side. You've not told us whether the ureters are dilated. They may, if the bladder is everted, may be pinched at the lower end because they're included in the inside-out bladder, and so there might be some hydronephrosis. There may be a history of recurrent infections and other problems. There may be renal functional issues. She may be poorly nourished with renal failure. All of these things you need to address. You know, there's no quick fix and there's no rush to do it. But these are the patients that test you. If you do bladder exstrophy surgery, the case I've presented are relatively straightforward. It's the redos that are the challenge. But I always think with redos, you've got a good opportunity to make things better. And oftentimes, you can't really make them worse. So I think it's a challenge, but it's a good challenge, but you have to change the environment completely. And if it's your patient and you've had several goes, you really have to stop operating. And I would apply that to myself equally. If I've had 3 goes at any kind of surgery, I really would think again before sending it back for another operation. The other thing to say, I suppose, after all of this, that I've met teenagers, I've met young people, I've met young men of 30 or 40 years of age who've still got bladder exstrophy, that wear a diaper, and not a particularly pleasant scenario in a hot country, in an African country, but have a near normal life expectancy. It's the surgery that shortens the life expectancy in bladder exstrophy, interestingly, not the bladder exstrophy itself, which is my principle for sending the patient home with a family. And it's something that you can't ignore in a case like yours, where maybe a strong decision is to say, well, we're going to look around for something to do, but for the moment, we maybe have a safe situation, so we don't have to do anything. The patient will have a view on this, of course.
I just wanted to echo and throw it back to you, Rayed, actually, because I need your help to actually put a perspective on what the strategy might be. But I just wanted to echo Peter's comment that I was traveling in India and I saw 23, 24-year-old young man with an exstrophy. Don't want to close, because it's not the disease that's going to kill you. For him, his priorities are to survival and to provide something for his family and his work. And so what if ever I am, because everything else is actually going to make me, and I think he was a wise person, possibly he wouldn't land up in a bigger problem for himself. But I want to throw back the strategy at you, ask you what you think, because you said, I think you said in your statement there were experts who came, dipped in and drabbed in, and I think as a center where you probably have a low volume, in Jordan probably, 2 cases a year or maybe 3 cases a year, and so you get these famous dare I say Americans coming along and then dipping in and doing another operation, and somebody else coming in and do another operation. And what is your strategy? What do you think now you should do for these patients? Because you have a responsibility equally when you invite these people to provide this care, and you wouldn't want this repetition of another child that's born with exstrophy and everything. So what do you think you would do now going forward as a strategy for your patients? You understand my question?
Yeah.
Tomorrow there's a baby with exstrophy born. What are you going to do? Do you want 18 years down the same situation, or what would you change?
He didn't tell us he did any of the previous surgery, and we didn't ask him.
I assumed. I just left like that because
to know whether he did.
it wasn't me anyway, and I'm sure it wasn't Peter. But yeah, you understand where I'm coming from in terms of what you would do?
No, please, if you can clarify further.
Yeah, but basically what I'm trying to hint is that every one of you, or wherever we are in our centers, we have a responsibility towards our patients. In the UK, we decided that we will reallocate to 2 centers, right? So, but if you don't have that opportunity, you need to have a strategy, either to have a liaison with an expert who is actually committed to your place to come and do the work, or have alternate strategies for this group of patients, which is what I was trying to hint at. Of course, it was not an examination question for you, but it's for everybody to think about what we need to do for our patients.
If you don't mind, Dr. Peter, I would like to ask a question, maybe as well because actually today I had been surprised that the Manchester moderate stage or delayed runner repair results and outcomes are very different from the Great Ormond Street ones. And you are in the UK, and you have been able to have only 2 centers to concentrate the work. And the basic principle for that is that the outcome. The outcome in different places is different. So what is the benefits now of centralization if you have these 2 disparity, or this too much disparity in the outcome of these cases?
You, sir, have nailed it.
Yes.
You've absolutely nailed it.
This is the reason why I was... Sorry, you're
carry
getting...
on, because this is my lived experience for 25 years. I'm an idealistic type of doctor, okay? And I suppose in that way I've been a bit naive. The patient comes first. the child first and always, which is the original motto of Great Ormond Street Hospital. And I sort of believed that when we started our journey through specialization in bladder exstrophy, there would be a comparison along the way to what was happening, and we would opt for the best option. Yeah, we would evolve, we would develop, and that best option would be totally supported. Now, I have to say that within our healthcare system, my voice advocating that we chose the best option, unfortunately it happened to be the option that I was using, and that was demonstrable with the statistics and the outcomes, was not a popular voice, and that voice was quietened, and that's why I don't work there anymore. So that's interesting, isn't it? But this comparison has always been there to make, and each hospital has its reputation to protect, and each hospital perhaps respects that the other's reputation is as important as their own, and so they don't challenge it either. And so as the doctor wanting to evolve a better treatment for patients, you end up stuck in the middle. And I have to say I'm a bit disillusioned with it, but those patients do exist. There's nurses and doctors amongst them. There's a Cambridge graduate amongst them who came top of his year, who was born with bladder exstrophy, and I showed his picture at the end with his parents. That's the reason that you do surgery. That's what really motivates me. Changing the world is probably a step too far. But we've all got a responsibility as individuals to do that. You see, I can't create any change by myself. I tried my hardest. I looked after the patients I was given to look after to the best I could. And that's what we all have to do. And if we find agreement, anything that you do and decide will influence the total outcome. And if you decide to do nothing, well, that's also not going to influence it. So it's a challenge, isn't it? It's a real challenge. And you absolutely nailed it.
Yeah. Can I just come into this one in a different angle? Because, as I said, I'm an observer, and I've praised Peter enough now, so I don't need to be, you heard it yesterday and today, fantastic surgeon, and he's taught me a lot, and I do believe whatever Peter is saying in terms of results. And you asked a very relevant question, and I struggle with this even today because I have a responsibility to my patients, and I refer to the centers and ask what the outcome is, what's the right thing for them. Peter is in it, so I don't think it'll be fair, because I can only say that I can see two centers, and if my colleagues in Manchester say this is what they're trying to do, and that's why I asked them, I rang them before coming here, because I knew I'm going to get into this situation, but I wanted to bring this debate out. I wish I can have this debate in the United Kingdom. But nevertheless, there are two centers, so there are two answers to this question. First question is, what is the point about, you said, about bringing them to two centers and then seeing what the outcomes are? That's different in understanding the outcomes, and there are multiple factors, including human, politics, so many things there, like human factors we talked about yesterday, and I participate in every other panel that you want to talk about in long-term disease, surgical pride and everything else. That's different from providing the care that you can the best way to the children. If you do one or two severe hypospadias, as I hear, you are not going to have the same outcomes like you're going to have if you do 50 to 60 a year. We define as at least 50 to 60 hypospadiasis you must do regularly to be able to do that, correct? So the principle of keeping it in a few centers, in a few surgical hands who got the skills is correct, which will avoid disasters like Wright spoke about or somebody else's one. We are all not immune to it. But the second aspect you talk about is human factors. When there is so much at stake, and everybody wants to say that my way is the correct way, that's a different argument. So we should not conflate what is our responsibility to our patients. Now, Peter could tell me around and say, well, why are you sitting here? You're not even an extrovert patient. But that's not correct, because in the community, I see these patients post-op sometimes. They come up there. We've done augments on these patients sometimes. So we have a joint responsibility of looking after these patients. But it is correct that you must restrict it to a few centers with expertise to do it properly, but do it with resources. I think, as I said again and again, struggles with some other countries is because they do not have the resources, including nutrition. Then you come to outcomes that people are twisting. That's why I'm sick and tired of hypospadias literature anymore, because it's not truth.
I think that that politics and bureaucracy has a very good way of constructing excuses for things that are unexcusable. All right? And I think that every surgeon has their own personal responsibility for which we will answer at some stage. If you're Christian or you're Muslim or even agnostic, there will be a time of reckoning for all of us when we reflect on our career or others reflect on our careers for us, or God does. So,
Okay.
I'm going to pick up my microphone and stand up there like
I have a
But
question.
the question I would ask, if a surgeon is doing an operation and they know that it's not working, should he continue doing it to avoid the loss of face?
No.
Who's the victim in that case? It's the patient, isn't it? And what we see in surgery developing depends upon honesty and self-criticism amongst surgeons. When my daughter was playing field hockey at school, I went to see her. She was 13. She was playing in the school team against the high school, the big school down the road. And they won. The high school won 3-0. At the end of the game, Lucy went round to all her friends and said, "High five, well played, well played." She got in the car. I said, "Lucy, you were rubbish. You were rubbish. How are you going to beat that team if you think that you were good? Because you were beaten." She was very upset about this, but now she's a doctor. Now she's a doctor. She works in intensive care in Bristol Royal Infirmary, and she gets it. Because self-criticism is the path to improvement in any field, not least of which surgery. Because if you're self-critical, you go and ask somebody, or you get someone over to help you, or you start thinking about changing what you do to get better. And that, I've found, is one of the most exciting things in surgery. And if you believe in audit, you can actually monitor your progress through those things as you change. And it's a very dynamic aspect of surgery which perhaps other doctors don't have. And if we neglect it, it's to our detriment, but mostly to the detriment of our patients.
I'm sorry, we're running late and we have to start.
سؤال يا محمد سؤال.
You started,
Questions.
Brad.
We shift
متأخرين.
from the philosophy بس. The timing for augmentation for cases indicated. For the questions for Peter and Ram.
Time what?
Timing of augmentation for cases indicated for that. Yeah. The proper timing for
Oh, for any patient.
augment.
Is only Exstrophy or anybody?
Exstrophy.
Well,
Okay, I have to say, I can say very clearly one statement for me. I do less and less and less augmentations now than I used to. When I came to Leeds, we were doing probably 7, 8 a year. Now I do 1 in 3 years or 4 years. Primarily because my research background is about tissue engineering and to provide an alternative to the bowel, to the urinary tract. For the same reason Peter alluded to in terms of the risks that's involved. So as far as possible, I want to do less and less. But to look at 50% augmentation rate for me is like scary, so that's why I put in the fact. But I'm not an expert.
I'm asking about the timing.
Okay.
As soon as timing, when can you do augmentation?
I've been asked for my wife's telephone number.
We're coming to the panel. All these,
What I
all
would
these are
say
the
is this. What I would say is this. When we created the standard avoiding continence, every patient wants it. Of course they want it.
Huh?
They see their
Panel,
peers
yeah.
gaining continence. And because it's an evolving thing, we didn't create an end point. In my mind, if they were not dry or showing good signs of continence after 5 years, I would want them to be augmented and dry substantially earlier in their school careers than many of them have been. Many of them have held on because their parents don't want the catheter, the parents don't want the augmentation, the child doesn't want another surgery. And as they get older, that they become more resistant to surgery. Now, some notable cases have become dry in their teens. But many cases have waited and put off surgery, which is my regret. Because I wanted to move to cystoplasty once I'd established that the Kelly operation hadn't worked. Now you can see these are relatively a minority of patients, 15 to 20% of all the patients, but they're significant ones because they're the ones that you see in your clinic, the ones that have still got problems, the ones that you really want to take over the line and get them dry. So I would propose that by the time they're 8, if they've not had success from their Kelly operation, I would do an augmentation cystoplasty, knowing that that's the age in which they will take up the catheterization for themselves. But the best time to augment any patient is when they ask you for it. I want to be dry, doctor. Please, can I have this operation? And some parents are resistant and the child asks for it. And I push the parents to let that child have that operation because it transforms their lives again when they become dry. So that's a complicated answer to your question, but I think you'll see it's based on my overall philosophy.
Excuse me, all these are panel questions, and we haven't started the panel yet. So this was the panel questions. Can we start because we're running late? Like we have less than half an hour for a long panel. Welcome you to the panel. Now we have a baby just born with a classic bladder exstrophy, male or a female. Do I have? Yeah, well, boy and a girl. Do I have the hand? Next. Oh, أنا عاوز الكنترول. أنا عاوز الكنترول معايا. ليه معاك؟ Lights down. Bladder exstrophy pathology. All of us know about the pathology of bladder exstrophy. Peter has explained that very well. We know that the diastasis pulls the corpora back, so we have a natively short phallus. So what factors influence the choice of the repair of a neonatal fresh bladder exstrophy? Next. There are 3 current trends for bladder exstrophy. The modern staged repair that has been premiered and popularized by Hopkins guys, Gerhardt and Ranjit Matthews, and the Seattle guys, Mitchell, the complete primary repair or the presumed complete primary repair. And the third option is the radical soft tissue mobilization, Kelly and colleagues and this school. So we have 3 schools, the planned multi-stage repair, and the complete primary repair, and the radical soft tissue mobilization. Next. So these are the most common factors influencing the choice of the approach for neonatal bladder exstrophy. So we'll start by the panelists. Ramnath, your choice for a fresh neonate with a bladder exstrophy. These are the most common factors enlisted in literature.
I think I would assume that early closure is the best thing. As I said, I'm not
You transfer to great onset?
Yes. I will send it to my colleagues, Manchester or London, wherever the patients prefer to go. But I mean, if I have a view, I would rather close it early because I can see what Peter is saying in terms of benefits, and I'm sure I'll use experts to argue on that. That's fine.
I said, if I had a choice, I would do it early closure, obviously, for the distress that caused to everybody watching, seeing it, and the easy to which able to achieve a decent closure. But I'll pass it on to the experts.
I mean, I've had the benefit of telling you what I would do. I would see the patient, counsel the family, and send them home for 2 or 3 weeks, and then bring them up for a slightly delayed primary closure, and make it a simple closure, so that I can set up the Kelly operation for around a year of age.
Bladder closure, what about the bladder neck? Just the bladder neck, no phallus?
A simple bladder closure. No bladder neck procedure. And in your 3 alternatives, what you didn't specify for the radical soft tissue mobilization is that the results I've shown you is in a staged procedure following a successful primary closure. Those people, Mark Leclerc and others who've been doing it all in one go, have far less continence.
True.
And smaller penises. And I can show you the geometry of that, but probably not enough time. But there are geometrical considerations when you move everything in one go, and continence doesn't work out as well. So the proof of the pudding is in the eating, isn't it, really?
So it's a delayed primary repair with a radical soft tissue mobilization later on. That's your choice.
Yeah. But I think that you don't have to rush. There's dogmas here, isn't there? One of the dogmas is you have to close it very quickly so you can take the bladder exstrophy away. Well, we can't take the bladder exstrophy away. Everyone's got to face up to the fact the patient's got bladder exstrophy. That's the best way forward psychologically for the whole family. Don't steal the baby from the mother and give her back a nicely healed abdomen, because she will not understand the problem that that baby has for their whole life. And that's been a massive problem that I've encountered. And therefore, the policy that I propose, let's face up to the bladder exstrophy. Let's see it. Let's touch it. Let's look after it. In your home, show your close friends so everyone understands the implications that this may bring to that child, so that their expectations are set correctly and we have a good team, unified approach to what we then do. It works much, much better, and actually it heals better because they're better nourished.
Yeah, in my practice during I would say the last 30 years or so, I was very much inclined to do a primary repair. But when we're talking about primary repair, even in neonatal period, we have to be honest about the facilities which we do have. You have a good NICU, neonatal intensive care unit. Do we have a proper pain management for this patient in this period, this age? So if we don't have this, when we moved from one place which I don't have these facilities, I will think more than once to doing neonatal repair. Dr. Naggar is a very close friend of mine. 1.5 years, 2 years ago, we have a patient repaired at the neonatal period. And it gives a lot of hard time because the both ureters are not post-operative. There is no urine coming except a few drops and few milliliters. And it becomes a period I call Dr. Osama, what I'm going to do. This is the third day, the blood urea and creatinine started, and he started shouting to me, Isam, you have to stop doing that in neonatal period. Because he knows I'm very fan for that. So from time to time we face problem. Fortunately, the patient at the fourth day of life started to have urine and the blood urea and creatinine, but it was very risky and it was a very hard time for me. If we don't have the facilities to manage this patient in this period with all coverage and all backup of nephrologists around, I think it might be reasonable to think about delayed primary closure. But the problem also in my home, we don't have a proper care of this bladder bleed. We send the patient to home, probably 50%, more than 90% will come with very bad bladder with these polyps and so on. So we lose the chance of doing this with a very nice source. One also point of doing in primary repair still nowadays, because we don't need to do osteotomies. I'm very much now becomes enthusiastic after reading about there's to skip osteotomies even at 3, 4, 5 months old child, because this one of the areas which was actually pushing us to do in the first 72 hours that will not need osteotomies. But thinking that it can be done even at 3 months, this another will be an issue. So just to find out, up to now my practice still to do it in primary if all the facilities are available, but by the point raising now and with confidence to do it without osteotomy even in the first few months of life, we might consider doing a delayed primary repair.
Osama?
Actually, the protocol that I'm adopting, I try to put as Dr. Assam said, the facilities that we have. And in general, neonatal surgery in Egypt, to be honest, is not good. So first of all, I avoid doing bladder exstrophy in the neonatal periods. Even if I know that there is some changes in the bladder and the polypoid changes and all these things, but we take the support from the Manchester publication that there is no difference if you do a primary closure of the bladder or you have a delayed repair. So, and as well the analgesia, and as well, actually, I believe that there is a need for immobilization after doing bladder exstrophy with or without osteotomies, and this is very essential one. And if you don't have a good analgesia and good neonatal care, so definitely disruption will occur, and you will have the same situations after 10 or 14 days after you do it in the first 72 hours. Actually, to take that for granted that in the 72 hours, all patients will not need osteotomy, I don't believe in this, because even in the first day, there are some phenotypes of the extrophies that they will need. What I'm calling, I don't know it is right or not, the bladder exstrophy patients are born with disruptive forces. I mean that the anatomy is getting the bladder out. There is something that wants to get rid of the bladders. And these disruptive forces you have to counter attack during your repair. Whatever you take a bit from Kelly, a bit from Manchester, doing osteotomy in a different way, it's not necessarily to bring the orthopedics. I'm doing a pubic rheumatomy. And if you imagine the pubic rheumatomy as if you are making mobilizations of the neurovascular bundles, although you are not making a detachment of the corpora, but still you can get some benefits in the length of the external genitalia, which as well is a very important aspect when you plan for doing bladder exstrophy. To summarize, I don't do it I do delayed primary repair, better between 3 and 6 months. In the first year, I do pubic rheumatomy. After first years, I have to do one of the classic osteotomies, anterior or posterior osteotomies. And as well, I try to make some sort of fast tracking, because we cannot tolerate the presence of a child in taking a bed in the hospitals for very long times. So I'm thinking about fast tracking bladder exstrophy patients. And I think that I can do this. I can say that we can do this in a way that the patients can be home after 7 days. With the applications of the heavy spica, in addition to the pubic rheumatomy and the heavy spica, all are counteracting the disruptive forces. And as well, I'm doing anterior abdominal wall component separation, because as Dr. Peter said, the anterior abdominal wall defect, if you don't close it properly, you will not have a successful outcome. So I do all these things together, in addition to, in the first stage, in addition to some mobilizations like Keely doing. To be honest, I'm afraid to go to make the neurovascular bundle and this mobilization of the corpora and getting them outside. Always my nightmare is when I do this, I will have the 2 corpora outside in my hand. So this is in addition to, a different surgeon, of course.
We are pediatric surgeons. We can even deal with the problems. Usually, for the long times, you have a good NICUs, neonatal intensive care. Usually, the plan also in male, not the female. For me, neonatal male, not all the time like the plan of management of neonatal female. First of all, I look for the associated congenital anomaly in the urinary system. It's very important, the kidneys, the ureters, there is no hydronephrosis, there is no associated double moiety or something like that. Second of all, the child must be a full term. If the newborn is a full term, there is no associated congenital anomalies, elsewhere, cardiac or renal or anywhere. And there is a plate. The bladder plate is good by any method of assessment, by the thumb. The plain X-ray show a narrow space between symphysis, wideness of symphysis pubis. I can do the primary repair with genitoplasty in the female, but without genitoplasty in the male. Because usually my philosophy, like the pediatric surgeons dealing with undescended testes, usually in our mind, we must track it and get it in the proper place, regardless the functions, how the tractions can affect the function of the testes. Also, the flow of the urine is not a problem. It can be managed at any time, but it is very important to keep the genitoplasty in a male and a female. I think it's very important in the plan. If this criteria is not present in the newborn, usually we do a delayed repair in a way of close follow-up. Because I ask about, is there a specific time for the bladder plate to get capacious and to big, more voluminous? And what's the factors affecting that? It is the nutritional factors, or how the bladder is stretchable. Is there anomalies in the fibers of the bladder? So during the follow-up, I can get, surprisingly, the bladder after 1 month or 2 months is very capacious, and I can close it. So I can do a delayed repair at any age. Maybe after 2 months, maybe after 6 months, maybe at 1 year. With the same plan, the female, complete repair, and for the male, we do bladder closure, and we do a release incisions usually in the abdominal wall bilaterally to make a closure, a good closure of the abdominal wall.
Okay. تفضل. دكتور عصام.
Without osteotomy.
3 years ago, we have a panel discussion on bladder exstrophy at one of the meetings of the Egyptian Pediatric Surgical Association, EPSA. And after the session, one of my colleagues said, Isam, I have an excellent results of bladder exstrophy. And I think Dr. Cacao, Mr. Cacao, today has outlined that. I have asked him a question. What do you mean by good? And I realized that good for him that he was able to close the abdominal wall. And that this is a good outcome. And this is all about the bladder exstrophy. How do you, and I think I don't need to repeat what Peter has said earlier. So he doesn't know what has because I know the problem in Egypt, we do not have a proper follow-up. We don't have a proper medical record. In most of the hospitals, I would say, some of them they have. But how to say good? How about the bladder function? How about the incidence of rupturing the injury? How about the scarring of the kidney? How about the continence later on? How about the growth genitalia if they're male? How about the erection? How about the genital? How? Okay. So it's a long questions. Okay. My problem with the bladder exstrophy up till now is I would say you find some data from reputable hospital, reputable centers of bladder exstrophy, and then you have something opposite. And this also has been outlined in the lectures of our honorable guest speaker earlier today. So this is a problem. We used to do Mitchell, we're gonna do Mitchell, because this is gonna increase the size of the bladder.
Okay, thank you.
Improve. And then it started to have something opposite to that. So it's I think at the end of the day, we should know your capacity as a surgeon, know what is the institution you are working at, what kind of follow-up is available, and then you make your decision for the best of the child, not for the best of the surgeon.
Is that okay? هو شغال كده ولا مش شغال؟ Next. Go back. This is not the next. Next. Okay, osteotomy. So these were the osteotomies that we used to do long ago. That was like over 20 years ago. Next. For those who advocate osteotomies, whether in the fresh or the redo, there are four. The most common type of osteotomies are the posterior iliac osteotomies, or the anterior iliac osteotomies, or the diagonal osteotomies, and the anterior pubic osteotomies. So which osteotomies do you prefer, if any? Ram? No?
No, I have no view, sorry.
Okay. Peter?
we do osteotomies, it's through the anterior superior aortic spine. Just lift up the apophysis of that and cut back down into the sciatic notch.
Oh, okay, is that the green one?
No, it's the black dotted one.
It's not black. There's no black.
No black.
The green? Where? Is that here? That's the anterior.
There's a dash one from the anterior superior aortic spine.
That's purple.
Is it purple?
That's the
Okay.
You got it, yeah. So this is the diagonal iliac osteotomy. So these are basically anterior osteotomies. This is the classical or the posterior osteotomy. So you prefer one of these. This is the anterior and this is the diagonal.
I mean, to be honest, that's the only one our orthopedic surgeons done.
There are quite a few.
30 years, that's the only one that orthopedic surgeons in Great Ormond Street Hospital have done.
When I visited Hopkins, like maybe 22 years ago, they had six different types of osteotomies with iliac bone resections and grafting. There's so many osteotomies. So, Assam?
Doing anterior.
Anterior.
Yeah.
Okay.
Right.
Which?
Right.
Right.
Okay, the pubic. The pubic. Okay, the pubic. Okay, the anterior pubic. But that's...
We're talking about osteotomies here, but I mean, who would prefer to do an osteotomy or prefer not to have to do an osteotomy?
Yes.
I mean, it's almost like we like breaking bones. I mean, I think breaking bones is absolute crime if you don't have to do it. And wouldn't it be better if you didn't have to do it? I think I've demonstrated that you don't have to do it. So osteotomies is in reserve, but not a primary treatment, in my view, in classic bladderectomy.
Yeah, that's right.
If you didn't have to do it, you wouldn't do it, would you?
But if you have to do it, how to do it? This was the question.
It is a fact that even after osteotomies, the pubic bones diastase with age, but sometimes they are mandatory in redos.
Yeah, but Johns Hopkins always does osteotomy, and their dehiscence rate is 8%. 8%. They do osteotomies in every single case. We don't do osteotomies in any primary cases, and our dehiscence rate, I've shown you, is less than 7%.
They don't do radical soft tissue, right?
No. I showed you the results of primary closure.
Yeah.
Without osteotomies, and the dehiscence rate, the reoperation rate, not the dehiscence rate, but the reoperation rate, which was not just for dehiscence, was 7%. And currently, at the ESPU, Johns Hopkins presented their protocol for preventing dehiscence, but they do 2 osteotomies, and they do gallows traction, and they keep the patient in hospital immobilized for 6 weeks, and their dehiscence rate is still 8%.
Yeah.
And yet they spend 10 times as much money on each individual patient to achieve an inferior result. I mean, what is that about? Really, how can you justify that? You don't have the resources in this country to keep patients in an intensive care for 6 weeks with bladder exstrophy. You don't.
Yes.
So, you know, there's other ways of doing it. And osteotomies is a distraction. The results of primary closure, if you got primary closure right, then you or the patients would move on to continence. And that would be the meat of the discussion, which has not been about so far. It's just been about success of primary closure and whether or not to do osteotomies. For me, bladder exstrophy is not about that. Bladder exstrophy is about continence. And it's about sexuality and reproduction. These are what these parts of the body are for. So,
okay, coming up next.
Just to this point, Dr. Mohammed, I just would like to ask, if you are not doing radical soft tissue, the repair, keloid repair, or Dr. Bukhar repair, how will be the frequency of needing osteotomy more?
The question is, radical soft tissue mobilization obviates the needs for osteotomy, yes.
Yeah, Peter has shown very nice to us that if you're doing Kelly, that you may not need osteotomy even at that age of 3, 4, 5 months. But if you do some technique other than radical soft tissue, if the incidence or the need for osteotomy will be the same, this is a question.
Yeah. But do you agree at least that osteotomy is mandatory for redo? for redo,
Yes.
not the fresh,
Yes.
for redo.
Yes.
Is that-
It's not mandatory.
Not
I-
mandatory.
That's again, yeah.
I work in Oslo. I have the honour of operating on Norway's bladder exstrophy patients. And I visit twice a year for 2 days, and I do CAICC operations. But occasionally, when they do the primary closure, because they do them locally in Tromsø and in Bergen and in Oslo, there will be a dehiscence. And I only go every 6 months. And before we had the availability of an orthopaedic surgeon, I would occasionally close one 6 to 9 months following a primary dehiscence with some success. Although given the choice, I would prefer to increase the odds of success with osteotomies in those cases. But that might also be a dogma. What we've got to do is to try and examine why we do things. Do we do things because someone tells us to do it? Do we do things because we've always done it? Do we do things like they do in Hopkins because we've employed an orthopaedic surgeon just so that he can do that? You know, there's all kinds of reasons why we do that, which have nothing to do with the treatment of the condition.
There is a wisdom about this question.
Dr. Peters, do you immobilize these patients in the
No,
primary?
no.
And this is the problem. This is what we find.
No,
This is my experience, and the experience of many others.
But we don't immobilize them when we
if
get
you-
good results.
Okay, there is something that we are missing. But we tried all these things because we have the luxury to try. So we tried doing it in the neonatal period in the first 72 hours. And we tried to do it at that time without osteotomies and without immobilization and just wrapping the child in a mummy wrap and DDS. And they open. Maybe there are other factors. It is not the surgeon. It's not the case of operation.
Hundreds of other factors. And if we just focus on these one things and believe that if we change this one thing we'll make it better, then we're maybe not looking hard enough at what we're actually doing. And we're asking other people what they're doing and seeing what they're doing. But I worked with Philip Ramsey, who was the best surgeon I've ever worked with. And when I was working with him as a trainee for 4 years, he tried all kinds of things, including immobilization in ITU and ventilation electively for up to 2 weeks, osteotomies with external fixators, osteotomies with hip spikers, osteotomies with gallows tractions. We still had lots of dehiscence.
Why?
As soon as we stopped doing osteotomies, our dehiscence rates went down. Funny that, isn't
The
it?
osteotomy was a cause of dehiscence.
I think it's a contributor. Every single one of the patients lost significant amount of blood and got, if they had pin site infections with a staphylococcus, sometimes MRSA. Every
5
single
minutes.
one. Half of them
Give me
needed a
5
blood
minutes.
transfusion. I don't think that contributed to the success of the primary.
Can we move on? Outcomes. We like to look at outcomes in terms of upper tracts, social dryness and not continence, and the sexuality and fertility later on. All of that sum up to the quality of life. What is the prime outcome that you are looking at when you decide on the initial closure? What's your, what do you consent the parents for, Peter?
I tell them that currently it's around 70 to 80% chance that their child going through this process will be continent by the time they're 10 years of age. That's what I'm wanting.
How do you define continence? What did you tell the parents?
I showed you.
Okay.
I define continence. I showed you how to, because I'm the only one that's defined it.
Yeah.
All right, you haven't defined it. You've used this term social continence. What is that? What is that? What does that mean?
Well, social dryness, not continence. I would say
Yeah, what does that mean?
they have to be adjusted to the.
What's that mean? How do you rate it? How does the patient understand it?
Well,
I'm pushing you here because
Yeah.
I've had this argument with all kinds of people.
Yeah, I agree.
Most of whose papers have been shown by colleagues here, by Rich Brady, God rest his soul, and Mike Mitchell, and John Gerhardt. And there is, continence is what you can do.
The quality
It's
is
what I can do, it's what you can all do. I mean, we've sat here for 2 hours now.
But now,
There's no puddles on the floor.
the definition,
We're given the opportunity, we'll go somewhere else and empty our bladder for the next slide.
the definition you have given is the definition of the surgeon. I will say that. But if we come to the quality of life, how can we decide that the degree 1, 2, or 3 is the patient and the patient's family are happy with? if you want to say that he is continent grade 0, 1, 2, 3, the quality of life is something different. This is what we think that this is incontinence. How can we know that?
Correct.
This
I think
the quality of life of these patients.
You're absolutely correct, and I think the problem is asking surgeons to define what their outcomes is the worst thing ever, really, because everything matters to each individual patient. And this is not just with exstrophy, it's with meningomyelocele. No, it's with meningomyelocele, it's with everything.
But if you say that, Ram, then the possibility of being objective and examining what you're doing and being self-critical about that is denied you. If you can't define the outcome, of course, absolutely in the long term, your patients, many of mine are in touch with me, and they phone me up to tell me how they're getting on. They're getting married, they're starting to have children, they've been to university. They've had the kind of lives that they couldn't have if they were wearing nappies for the whole time, and they would have been restricted if they were catheterizing for the whole time. I know that. They, in their wisdom and their nuanced understanding of their own condition, also understand that. It's a revolutionary thing to be continent, but we rarely achieve it in reconstructive surgery in the true sense, which is why it's so transformative when you do. Which is why I'm passionate about it, and why I'll keep respectfully disagreeing with colleagues. Because I think you need a mindset change of approach to change things. A little bit by this, a little bit by that, doesn't really do it. When we started to do the Kelly operation, it was a quantum difference from anything that we'd done before. And that made the change that Philip Ransley, bless him, had failed to do in his whole career. And he's the best surgeon I've ever seen. And I would put him against any of you guys, and you probably would, if you've seen him, agree with me. He's a very, very talented surgeon, but actually it was the concept of changing this and changing that and doing a little bit that didn't really work. And it's not worked in Baltimore, because we would be hearing about the 80%, it would be blared from the rooftops, and those patients will be wheeled out to see us at every meeting, but they're not, they've gone quiet.
One more.
But they've done exactly the same process of trying to change
One more run.
Oh, I'm just trying to encourage a mindset, a quantum, if you like, into something different. Because that's probably going to be more successful.
That's why
One more.
That's why you're having the panel, that's why you invited me, of course it is.
One more run. Sorry, we were late, but the bladder neck repairs. Rationale, techniques. If you regularly use a bladder neck repair, these are the most common repairs: the young D's, the Mitchell, the Pippi-Sale, the bladder neck plication, the fascial slings, the bladder neck bulking, the artificial sphincter, or the bladder neck closure if everything fails. What repair that you choose, if any, and what is your rationale? Bram?
Well, in this case, I have had experience because of previous exstrophy patients from Leeds and stuff who came on the line and had to do some bladder neck. I mean, honestly, it's a really, really challenging situation. And I have not come across a perfect bladder neck repair that actually works across the board, not just these patients, but in other pathologies as well. And I find it very, very difficult. But I do more, if I have to do a bladder neck repair, then I would go from inside and then narrow it as long as possible, and then give an angulation, not just quite like the young D's, but a slight modification of it. And I know it's very different, and I have used sphincter as well, but the sphincters cause a huge lot of issues later on. And yeah, it's a challenge, and I don't have the answer. I really do not know.
Well, I've done it a lot with bladder exstrophy patients. And most places, when one travels and does an augmentation system, we might have one tomorrow, we don't know. I would always try and keep the bladder neck open. I think that you need a leak point, particularly when you create outlet resistance. Even if you're providing a cystoplasty, if you become reliant upon catheterization via Mitrofanov and you've got no outlet, two things happen. First of all, there's a significantly large number of patients who get bladder stones when you close the outlet. It's much more common than if you leave the outlet open. I don't really know why, but it is much more common. Our rate is under 10% in the first year. which is not acceptable, but it's lower than if you close the bladder neck. The other thing is, I think there's an element of danger. Patients occasionally will not be able to catheterize, and you need a leak point, or you need an alternative form of access. So I always do a long tuberization above the verumontanum. I used to leave it with a stent in situ, but now I make it around a size 10, and I leave it without a stent. But normally that leaves a passage, and if you create an intrapelvic segment of that, that's normally enough in a low pressure container which you've created with your cystoplasty to have enough resistance to stop them leaking. In addition, if it does leak, then you can go back and stick some deflux in there, which takes them into dryness if you need to.
Okay. Diversions. Last question. Diversions. What diversion technique that you prefer, and for what reason? Is it primarily saving the upper tracts or primarily achieving social dryness?
No diversion.
Secondary diversion. I'm not talking about primary. Secondary diversion.
No secondary. If I am going to have diversions, if I am going to have a problem with the bladder closures, I will do augmentation to the bladder plates with helium, and try to do a debag for the bladder neck, or sometimes you narrow it rather than closing it, and metrophenol.
Yeah, but again, this answer comes to the context. Because I was speaking to one of your colleagues yesterday, somebody said, it's very difficult to convince a patient in Egypt, he said to me, about having metrophenovs or, augments and things like that, because catheterization is not considered very, a stoma. They think that it's going to be a big fright thing. There's part of misunderstanding.
The mind is changing.
I know, but I'm trying to say, in context, it's not so easy. Again, coming back to everything is what is right for a particular area may not be right for the other area. And also augmentation is not without its problems. Mucus production, say things, it's a lot of discipline that's necessary. So we can't just say, yes, I agree, ideally this is what it should be, but it's different.
I'm saying what I'm doing. I'm not saying that's everybody is doing.
I think that I'm going to disagree there, because I think you have a bias against augmentation. But augmentation, cystoplasty and metrophenol change lives in incontinent people. And I think it's really important, if you say that it's not accepted, a lot of patients that I've treated don't want to have a metrophenol. They don't want to catheterize. But the moment that they do, they feel the benefit of it. Right. Universally. I've got 3 active Paralympians in the British Paralympic team that I augmented with a metrophenol. One of them at least didn't really want to do that, but his life completely changed in a very radical and wonderful way as soon as he was able to be dry and be in control of his own urine. And I think that what you need actually often with a patient who's not accepting the idea is for them to meet a patient who's had it.
Yeah. The challenge, Peter, is the journey to make them accept. And that's why you need support mechanisms, the nurses, as people to speak to them, show them videos, show them pictures of how it looks. It's not as bad as people think it is. But get to that is a challenge, in some communities particularly.
Okay.
And you brought about tissue engineering.
Thank you very much. And one last thought. What about, do you know anything about allograft bladders, transplants?
I do.
Cadaver.
I do.
Really?
Because I've spent 10 years of research in tissue engineering in the lab, and I've also reviewed the results of other people using different scaffolds, and we've got different strategies of creating new bladders, and that's one of the response was things. I think we are not there yet. This work by Tony Atala and people. Sorry?
I've been.
Allograft bladders, but no sphincter.
No sphincter, exactly. So there was what we call as responsible research. So when all this broke out, on the BBC it was announced that bladders are available off the shelf. We got phone calls from patients asking, where can I go and, as if we can go to the supermarket, pick a bladder and put it inside and it will work all the thing. It's not the thing. There are a lot of issues, the muscle, the motility, the nerves, everything that goes on with it. At the moment, what we have succeeded is to be able to provide good, large quantities of urothelium safely. Our own progress, our own team is in a journey, but it's going to take another 10, 15 years and get it. We are not there yet. That's the fact.
I was in Boston when on the team with Atala's team when they did the allograft, the tissue engineered bladder. They rushed and published it, but like in 1 month it's scarred down and everything.
I know, because their subsequent publication demonstrated that.
I've
That's what
been
I
there.
call as responsible research or fast food culture,
Yeah.
which is not correct.
Good morning, everybody. I would like to thank Dr. Saber and all the team of Nile of Hope for inviting me to participate in their first Congress, wishing them all the best of luck and success. After the panel about bladder exstrophy, we have this panel about cloaca. Next, please. Cloacal anomalies are the most complex form of anorectal anomalies. The term cloaca is used almost exclusively in the female to describe a condition where the intestinal, genital, urinary tracts join to form a common channel draining through a single perineal orifice. There is a classic form for cloacas, and there are other cloacal variants. Maybe we'll not touch in this presentation the classic cloaca. Next, please. This is how it looks, imperforate anus with a single perineal orifice at the site of the normal urethra. And here is a classic genitogram showing the common channel, the rectum, the vagina, and the urethra. Next, please. Cloacal anomalies are characterized by a high incidence of Mullerian duplication anomalies in the form of longitudinal vaginal septum, as in this case, uterine didelphys, bicornate uterus. Another peculiar finding is the hydrocolpus. In cases of cloaca, about 40% of cases, and this represents a clue for the antenatal diagnosis. Next, please. In this diagram, we can see here this MRI mid-sagittal demonstrating the anatomy. In cases of cloaca, we may identify the bony landmarks. Number one here is the pubic symphysis. The first sacral vertebra is another important bony landmark. We go down first, second, then the fused coccyx, distended urinary bladder, 2 hemivaginas, number 3, and the rectal fistula. A typical configuration is that it descends embedded between the 2 hemivaginas, as more demonstrated in the axial cuts. The abnormal communication between the vagina and the urethra makes like a valve-like mechanism, preferentially directing the urine flow into the vagina rather than to the outside, causing distension of the vagina, which in turn will compress the bladder neck and the lower ureteric ends and puts the upper tract at risk of hydronephrosis. Next, please. Therefore, it is of utmost importance during managing cases of cloaca in the neonatal period, not only to do decompression for the gastrointestinal tract by a colostomy, but also in cases of hydrocolpus, we have to plan for effective and early urogenital decompression to avoid damage to the upper urinary tract. There are several ways to do this urogenital decompression, whether to do a skin vaginostomy, tube vaginostomy, sometimes vesicostomy, or even in some centers they would recommend CAICC for the distended vagina. Whatever you do, please make sure that it is working to avoid damage to the upper urinary tract. Next, please. Then we go to the period of preparing for the definitive reconstruction of cloaca, and Dr. Durham-Smith described this period as a puzzle. You are trying to collect as much as you can from pieces of information representing the pieces of the puzzle. We can anticipate that the fewer gaps, the more effective your planning for a sound reconstruction for this anomaly. Next, please. What we use for investigations, different investigations, the conventional contrast X-rays, cross-sectional imaging, whether MRI or CT, and ultrasound. Of course, we can confirm all of this at endoscopy. We believe that all investigations do have limitations. but they can complement each other, which is quite justified for the complexity of this anomaly. Next, please. Going through the history for anorectal anomalies, of course, an important landmark is the work by Dr. Douglas Stevens in Melbourne, Australia, who extensively, and his colleagues, studied cadaveric dissections of stillborn with anorectal anomalies, and they set up the anatomical concept, the famous pubococcygeal line, to differentiate between low and high anomalies. Despite being useful in other anorectal anomalies, this concept was not very helpful to classify cloaca due to the presence of many other variations, not only the rectum, whether it's low or high, but there are other variations in the urethra and the vagina. Next, please. Another important landmark refers to Dr. Hardy Hendren, Boston University, who, based on his great operative experience, he distinguished the anomaly at different levels: the perineum, urogenital sinus, and the vagina and rectum. Next, please. And lastly, Dr. Alberto Pina, he just simply classified cloacas into either two main types: a benign low type, depending on the length of the common channel, whether it is a short common channel. Of course, this will be associated with a low vagina and low rectum, or it is a long common channel with a high vagina and high rectum. Others added the length of the urethra, which is another important measurement to be used, and they also set a cutoff value of 1.5 centimeters. Next, please. While applying these measurements, we have found that there are some limitations measuring these very small measurements with approximation errors, and it doesn't consider the variation of the age or the body mass. So we, inspired by the work of Dr. Stevens and Dr. Hendren, we thought of putting some anatomical concepts in addition to these well-popular classifications. Next, please. So we dissociate the cloaca into its two basic components, the anorectal component and the urogenital component, and we study each component separately. One of the advantages is that although the degree of severity in both components are usually, but not necessarily comparable in both components. Next, please. So here we start by the anorectal component. To the left side, we can see here the rectal descent in the pelvis is variable. First important landmark is to define where is the first sacral vertebra, and then you can count down. In this case, we can see that the rectum is descended in till the level of the fifth sacral vertebra, and we can anticipate that this can be comfortably approached through a perineal approach to mobilize and do the anorectoplasty. At the extreme, to the left-hand side, we find the rectum is high up, opposite the first sacral vertebra. Practically, this rectum is in the abdomen. It's not in the pelvis. You cannot approach it from the perineum. In between, in the mid-pelvis, this is a gray zone. It's doable through the perineal approach. Other surgeons with maybe more laparoscopic skills would prefer to approach this case through the abdomen from above. So this is the level of the rectal descent, how it affects your decision and your planning. Next, please. Next. Yes, this is an example. Here is the rectum opposite S1, 2, 3, 4, and here it's comfortably approached through a perineal posterior sagittal approach. Next. Here is a higher rectum. Still, we could manage to mobilize and dissect the rectum and do the anorectoplasty through a posterior sagittal approach. Next. Here, opposite the first sacral vertebra, no way to mobilize the rectum from down. You have to open the abdomen or do a laparoscopy. Next, please. Not only the rectal level of descent in the pelvis is important, also how the rectal fistula joins anteriorly with the urogenital tract. We have observed two main types. Whether the rectum directly communicates with the common channel, this is a rectocloacal communication, or the rectum ends first into the vagina, and then the vagina joins with the urethra to form the common channel. We have observed this type, lower type, recto-vaginal communication to be more benign, because the rectum here acts as a vent, deflating the vagina. Here the incidence of hydrocolpus is much more less, and also the upper tract dilatation compared to the rectocloacal communication. Simply when you inject the contrast through the distal loop, contrast will flow directly in cases of rectocloacal communication to the outside, but in recto-vaginal communication, you will find that the contrast passes first to the vagina and then to the outside, and you can confirm this at endoscopy. You can see in this case the rectal fistula outside the vagina. Here is the septum, but here the rectocloacal communication, the rectal fistula is inside, just below a partial longitudinal vaginal septum. And next, please. Very rare occasions, we can find the rectum communicating with the bladder. Rectovesical communication is more common in the male, but still we can, in very rare occasions, very high types, we can see here two hemimularian structures and the rectum in between joining to the bladder. But the most common are either rectocloacal or rectovaginal communication. Next, please. Last information we need about the rectum is the position of the rectum in the pelvis in relation to other structures, and usually the rectum is the most posterior structure in the pelvis. However, we have the vagina to be located in place of the rectum. With a very high rectum, the vagina will take the place of the rectum. And you can see sometimes case reports in the literature, they do a rectoplasty and then they find that they pulled the vagina down. So this information, like what Dr. Smith said about collecting pieces of information to complete the picture before you go to reconstruct these structures. Next. These are the examples. This is the classic cloaca, urinary bladder, rectum, and the vagina in between. Here is another configuration, urinary bladder, two hemivaginas, posterior, and the rectal fistula anterior in between the two hemivaginas. This is another variation when we have asymmetry of the two Mullerian units. So here, one hemivagina is distended. Here is the uterine cervix, the bladder, and the other is absent, and the rectum taking shifted to one side. Also here, two hemivaginas, one is distended and the other deflated, and the rectum shifted to one side. This information will help you before going to the operative room. Next, please. Here example how investigations may be integrated. The conventional studies, sometimes the overshadowing prevents proper understanding of the anomalies. The cross-sectional imaging here may make it more clear about the two hemivaginas, the rectum, the high rectum, and the rectal fistula. And similar X-ray for this axial MRI can be, you can see that all investigations are telling the same information. Next. So this is the rectal part, and often the rectal anomaly is the easiest to recognize and the simplest to treat in cloaca, whereas the urogenital lesion may be the most complex and life-threatening. Next, please. So going to the urogenital sinus, whether we have a low or a high confluence, also this means a long or a short common channel, more or less than 3 centimeters. Again, this is a cutoff value proposed by Dr. Pena, or whether we will need to know about the urethral length, whether it's more or less than 1.5 centimeters, and its implication on choosing whether you will do total urogenital sinus mobilization or not. Again, these limitations in the measuring process and the approximation errors and the body mass index of the child, we sought to also to think of complementary anatomical concepts before surgery. Next, please. So here we would refer to the pubic symphysis because it's nearer to the urogenital tract. And we can see here, if it is the urogenital confluence, the lower end of the pubis, it is the end of the pelvis, and then we will go to the superficial perineal pouch. This is a short channel and good length of the urethra and a low-lying vagina. On the extreme, other end, we can see the urogenital confluence at the upper end of the pubic symphysis or above, and here is a high vagina, a short urethra, and a long common channel, and between intermediate part. We can, this diagram, we can apply it on real cases below here. This is a case. In the MRI, when the vagina is distended, it's easily demonstrated because it appears hyper-intense white like the urinary bladder. And you can see easily, you can detect the lower end of the vagina, which presents the site of the urogenital confluence. Here it's below the pubic symphysis. Here is the confluence is behind the mid symphysis, and here is a high type above the pubic symphysis. Next, please. Again, to make it more clear, as you can see here is a distended vagina above the upper end of the pubic symphysis, and this is a high, and you can anticipate that you will have this type. It's a long common channel. Next, please. This is a low confluence at or below the pubic symphysis. Next. This is again. Here you can see discrepancy. The rectum was very high. This is sacral to only two pieces, sacral dysplasia, severe form of sacral dysplasia, and a sort of caudal regression. Also the spinal cord was high, but it's not apparent in this section. We did abdominal assisted rectal pull-through, but this for, you can see here is the vagina, the urethra, the clitoris. This MRI is called fat suppression. We remove the fat to make it more clear for the small structures. After rectal pull-through, you can do just a cut-back vestibuloplasty to expose the urethral opening and the vagina. Next. This is, again, the vagina, the urethra behind the mid-pupils. Next. And we did a posterior sagittal for the rectum and urogenital mobilization for the urogenital component at 2 stages. Next. This is a high vagina. This will be approached through the abdomen. This is not in the pelvis. Next. And this patient had a vaginostomy that we cut it down, and then we did vaginal pull-through. Next. So I here want to emphasize on something else about the vagina. These 2 cases all have a high vagina in the abdomen, but the difference is that it is a small side vagina. You can see here the uterine cervix, but here is a distendable vagina. So in correct planning, it's not only the level of the vagina, but also the size of the vagina, because here you cannot, both will be approached from the abdomen, but here you have to prepare to get a piece of bowel to bridge the gap between this high vagina and the perineum. So you can't get this vagina down, otherwise you will get the uterus in the down to the perineum. And again, this is proper planning. I'm not going, in this presentation, I didn't go through the controversial issues about surgery, but it's about getting as much as you can from information before going to the operative room. Next, please. So this is the last slide. To summarize what we have presented, that in presence of hydrocorpus, it's of utmost importance to do effective urogenital compression at the time of the colostomy. Whatever you choose for this urogenital decompression, make sure that it is working. The preoperative assessment should identify the defect at both levels, the anorectal and the urogenital level. And remember that the defect at the anorectal and urogenital levels are usually, but not always, comparable. And we, in our practice, we think that these measurements and cutoff values may be not so practically applied, and I think we can reinforce them by some anatomical classifications. This can decrease the confusion from measuring errors and changing in the body mass and the age of the child. Next. Thank you very much. This for this case.
Second question from your big cases, I know from your series. is there a morphological picture of morphological outside can help you in suspecting the length or the type of cloaca from inside?
Yes, sometimes there is a special configuration when we have the vestibule is very narrow, and sometimes it's projecting tubular structure like a false phallus. This usually have a very long common channel, but the variations in cloaca are so many that they need to exhaust all the investigations, and of course it is very important to protect the upper urinary tract. This is a main goal in your management, especially during the initial management. You have to protect the upper urinary tract.
My last question is about the highly inserted recto bladder fistula. Sometimes it is associated with a short colon or congenital anomaly of the colon, or no?
Actually,
with megarectum.
Short colon maybe in certain areas, regions in the world, like India, they have a big series about short colon. I have 2 cases, and they both were males. Short colon. I didn't notice.
Difficulty in pull through or.
Maybe the short colon, Dr. Peter, about the colorectal exstrophy, it's another variant. They have short colons. Yeah.
Thank you, Dr. Amro, for an interesting presentation. We discussed some point with our panelists. Next, please. This is our topic to discuss now. First time, next, please. We talk about associated congenital anomaly. One of main problems in cloaca is associated congenital anomaly and how to manage it. Our question to Dr. Nancy, consultant of pediatric nephrology, associated urological problem, it's about 40% of cases of cloaca.
I think, Dr. Malak, it could be more than 40. 40, I think, applies to all the anorectal malformations. But when we come to cloaca, which is a more complex form of anorectal malformations, I think the association is more than 40. It can reach up to 80 or 90 again. The most common we see the renal dysplasia or renal agenesis, and these patients, a lot of them have single kidney, which make the situation more complicated. They have a precious single kidney. At some times they are not fully developed. They have again some renal dysplasias, which complicate the situation. I think this is the most common. We can see the single kidney, the pelvic kidney, the horseshoe kidney, and of course, the presence of VUR. All these congenital anomalies, either the VUR is primary, but in most of the cases, I think it's secondary to the bladder problem. All these anomalies determine the outcome of these patients and their quality of life thereafter. And this mandates the early monitoring and early evaluation of the urinary tract to decrease the burden on the kidneys. The presence of neurogenic bladder per se is a risk. Even we have normal kidneys, if these children have normal kidneys by ultrasound, they have no hydronephrosis or even reflux, the presence of neurogenic bladder is a high risk to the kidneys. This is the point. We have to search for them. We don't have to wait till this patient presents with UTIs or renal impairment or oliguria. We have to search by screening for these anomalies.
Thank you, Dr. Nancy. Professor Assam, what about your algorithm in patient of cloaca? How to search about associated congenital anomaly? What is examined first, and what is the radiological investigation you want to search about associated congenital anomaly?
Yeah, the question about how to search for other association anomalies in a baby born with cloaca. I think when we see a patient with cloaca, sometimes there is some indication during the prenatal care that this baby might have anorectal malformation and the issue of cloacal anomalies may come in mind. After delivery, we need to rule out other associated anomalies. Of course, one of the very important is urogenital anomalies, but still there is some cardiac and the other spectrum of the esophageal and all that, like the standard combination, to have to rule it out. And then to look for how regarding the prognostic factors. The prognostic factors, the presence or absence of how many pieces of sacrum and the sacral ratio. This has been outlined clearly by Dr. Pena and other publications. So we look at very good quality X-ray to look for the spine. And also we look, as Dr. Nancy said, to rule out any associated and urogenital anomalies, which is very common in such cases. The Mullerian structures, of course, we look for the abnormalities for Mullerian, but this is gonna come in the context of management, preparing or planning for the management. But what may be really to be addressed very soon if there is a hydrocolpus which is pushing the bladder neck and doing some sort of refluxing and vesicular refluxing or obstruction at the bladder neck.
Okay, thank you. Next, please. We have a case presentation for a non-cloaca patient with right transverse colostomy. He's aged about 6 months. She has single left kidney with grade 5 reflux and recurrent attack of UTI. The investigation showed by ultrasound left grade 4 to 5 vesicular reflux, physiology showing ectopic insertion of left ureter, single ectopic ureter, to be inserted either in posterior urethra versus bladder neck. Next, please. This is a picture for physiology showing dilated tortuous ureter inserted into posterior urethra. Professor Ayman, how can to manage?
I think in a case like this, you have to do ureter implantation because it will never improve by trial of medical treatment or trial of sting. So you have to do re-implantation, of course.
In 6 months?
Yes.
Yes. Dr. Peter, do you approve?
Well, I mean, the position of the psycho-ureteric junction precludes your satisfactory reconstruction of this, and you do need to move, of course.
What about the isotope scan?
Isotope scan showing the normal single kidney with normal
GFR, a normal GFR at this point. A normal GFR.
I think yes, it's normal.
What we need to know if this patient has a normal GFR or not.
What is it would be different about that? Is abnormal GFR?
Scan will dictate the urgency of each step. Would you first address the drainage of the upper tract, or can you even stress on it and go on for the lower reconstruction to be concomitant with the reimplantation or the reconstruction?
If normal GFR, we will meet.
You don't wait 6 months. Is already capable of starting doing this.
But Mohammed said, Mohammed said age is 6 months.
Yes.
6 months, yes. So it's just, do you need to get all the focus on the upper tract, or can you still, the upper tract is well functioning, and then you can start working on the same pattern of reconstructing the lower tract while on the same person doing the implantation or
Dr. Hassan.
Well, I'm assuming you are talking about a baby with diagnosed as cloaca, and he or she has a colostomy, right?
Yes.
And then at the age of 6 months, during further investigation, you have this photo. And the question is how it looks like the kidneys, the function, and if there is a marked hydronephrosis, and it might be a place for, this is a high risk because this is single precious single kidney. It might have a rule for decompression of the upper system until you're planning for the definitive repair, because reimplantation, I would say, in this early age, in this kind of bladder sometimes doesn't work, because many of these patients will have some sort of neurogenic bladder, so you may already don't like to take the risk of failed reimplantation or continuing to worsening of the upper system. So the first step is to do just relieve the kidney and then wait until the evaluation of the bladder, the status of the bladder, if the implantation will be has a decent chance of working.
It will be a dry bladder if we doing diversion or ureterostomy.
Yeah, maybe like ureterostomy can be
vasostomy.
Yeah, you can do
Dr. Bita, what about refluxing ureteric implantation?
I think you're a little bit of a difficult spot here, because if it's the bowel, that's fine. You can do a defunctioning colostomy, you can do your reconstruction, and you can join it up afterwards. But with the urinary tract reconstruction, you can't do that. With a solitary kidney, if you defunction it and reconstruct your urinary tract and then undivert your kidney into that bladder, the reconstruction of the urethra will fail. So actually, you've got to reconstruct the urinary tract with urine going through it. That's what I'm saying. So I think that you could buy time if you're worried about the GFR. There's a problem with infection. You could try and institute CAICC, see if that decompresses it, see if that gives you some form of control. Doesn't look like it, frankly. Or you could just do a loop ureterostomy, or even an end ureterostomy, because there's plenty of ureter here to be implanted at a later time. And then if you do an end ureterostomy, when you do your reconstruction from above or below, or probably from below, then you can excise the excess ureter stump and then go above and reimplant the ureter into the bladder as a part of that procedure. Because you're going to need to excise that lower part of the ureter because it's right in the wrong place. It's probably going to be right in the midline, just exactly where you want your urethra to be.
Thank you, Dr. Saber.
Yes, I believe that this child is presented with repeated recurrent urinary tract infection, and we look for the picture. The capacity of the ureter is more than the bladder. This is a single kidney. If we do ureterostomy, you are going to dry bladder and will be affected 100%. So I believe that the uretrovesical communication in a sort of a formal reimplantation or no, it is a very crucial effect. We minimize the attack of urinary tract infection, get the development and the capacity of the bladder, and you can control the upper kidney, the single kidney.
Yeah, but just can just highlight it again, because in some of these cases actually you were very enthusiastic to do reimplantation at the time of definitive repair. But we noticed that the reflux is continuing for some time, and the dilatation of the upper urinary system is continuing. And for a patient with just a single kidney, don't you think this is, the decision, our decision was not that appropriate in that case, because it's just, again, it's a single kidney. So at what time you would like to do reimplantation, and is there any specific time you say, no, not earlier than this age, I'm not going to do reimplantation? And how do you investigate the bladder from your point of view that this bladder is a candidate for reimplantation with a decent chance of success.
Well, what we don't have here is an endoscopic examination to see, because that would enable you to endoscope the bladder to distend it with your water or your saline and actually get a measure of its capacity. And actually, I think these indirect studies are fine, but I really like to get inside the patient at the end of a cystoscope. That gives me a really good feel for how everything's lying, and I can't emphasize that more strongly. I really like to get visualization. Do you have a cystoscopic view of this?
No, I didn't have now, but it's answer for next question. Next, please. Next. How to decide your approach? You said you do endoscopic evaluation. Next. Next. When do the endoscope and what are you looking for? Yes.
I can't see the vagina. This is a sort of
No, it's not the same one.
First case.
First case?
Yes, the first case, I think we have similar cases for this ectopic ureter. The vagina didn't appear. Sometimes you have it's very hypoplastic or even absent. I think we have to complete the picture before we. Of course, the kidney is the utmost important. It's a single kidney, but I think that this case, I have similar case. The rectum sometimes getting down and in the rectovestibular fistula, and sometimes you have no vagina, no molarity. So it didn't appear in the genitogram.
I think this was hypoplastic vagina, and when we did the PSARP, our staged operation, we faced the ectopic ureter first to be reimplanted. Okay. We will stop discussion this case until now and go in general discussion about endoscopic evaluation, how we do endoscopic evaluation, when we do evaluate and what we are looking for. Dr. Peter. When we do endoscopic evaluation and what are we looking for? Yes.
Yeah.
Doesn't it depend a little bit on the presentation, on the appearance of the upper tracts? If the upper tracts are okay, then prophylactic antibiotics plus or minus intermittent catheterization may tide you over until the child's, say, 3 months of age. And that's probably a better time to do it than in the small neonate, just because of the size of the scopes, the logistics of everything. You try and put it off till about 3 to 6 months of age, because you're not going to do any reconstruction before that time, unless you have to. So you defunction with the colostomy. If the upper tracts are okay, prophylactic antibiotics plus or minus intermittent catheterization, and then you take your time. In our centre, we do these reconstructions in concert with the general surgeons. So they'll do the SARP and the pull through at the same time as we might do the vagina and the urethral reconstruction through the same incision. They make the incision, we find the structures. Sometimes it's useful endoscopically, not just to evaluate, but to put little tubes through at the time, so you can find the structures much more easily at the time of your SARP. But I quite like, as I said, to get my head inside these patients. Even any complex patient with a closed bladder and different systems, whether it's diverticular, whether it's ureteric orifices, or patent uracuses, or cloacas, or UG sinuses, I like to get a 3D picture. I was brought up as a urologist, and when you're a urologist, and there are probably supposed to be a few in the room, you spend your time swimming up and down inside the urinary tract at the end of a cystoscope, looking for bladder cancer, looking for other things. Mostly check up for bladder cancer. You do 12 of those in the morning. And I remember swimming up and down, looking around and thinking, well, what's all this about? And that's how I orientate to the urinary tract. Some pediatric surgeons, I think, have a very different 3D orientation. They like the 2D of the imaging much more than the 3D of the spatial experience. But I really favour the spatial experience. I understand it a lot more. And that plays into all kinds of things. And you know a technique when it works, when in the most difficult situation it's successful. So I use that approach in conjoined twins with shared bladders, anterior, posterior, and then side to side. And it really served me well, having that orientation I was able to employ it in that most difficult situation. It was really valuable. So I would really advocate do as much endoscopy as you can, particularly in simple and complicated cases, because it serves you really well. I found for me, it's as good as a cross-sectional image.
Dr. Hassan.
I think ban endoscopy, I would say ban endoscopy is critical in the evaluation of a patient with cloaca. And as Dr. Amr has shown in his lecture today, MRI is nice, a conventional radiology is nice, but to be augmented by endoscopy. So the way to do by endoscopy is in two ways. The first one, I think it might be if you don't have a very large number or huge cases of cloaca, you should start by doing endoscopy first as a first step, and then try to look for the length of the common channel, how long it is, the urethra proximal to the confluence, the vagina, if it is the size and the position of the vagina and the entrance of the rectum. So you have to evaluate all the components, and then to look back and take enough videos, and just don't do anything at this stage. Go back and review all this finding with the senior colleagues. And by the way, this is the cases of cloaca should be done by the most senior person with the huge experience in that field. And then to sit with the radiologist maybe, and put pieces together, the pieces of puzzle together. And of course, as Dr. Peter has said, if we have 3D reconstruction will be nice, and they have done a lot of this work. Muhammad have done this work with Mark Levitz and the people from Cincinnati, and before moving to Nationwide and then Washington, D.C. They have a lot of these nice reconstruction models. So if you manage to get all these things, you will make life much easier during definitive repair. And as I always said, a failure to plan for cloaca is definitely as a plan for failure. This is one of the most difficult cases to address in pediatric surgery and pediatric urology from my point of view.
Thank you, Dr. Hassan. Next, please. Dr. Shaima, can we get more information from imaging? Next.
As Dr. Amr nicely illustrated, the value of preoperative imaging plays a cornerstone in planning of cloaca. Starting from the ultrasound. Ultrasound is a cornerstone in imaging. It's bedside, devoid of ionizing radiation, easily made, available, not need much experience, but it should be done by high-frequency probes, as it will nicely demonstrate the renal parenchyma, which is very important as a prognostic sign for the renal function. When we see echogenic kidneys with balloon decalces, this means with loss of corticomedullary differentiation, this means this is a decompensated hydronephrosis, or this is a decompensated nephropathy. When we see renal cyst, this means sort of renal dysplasia. Ultrasound also nicely demonstrates the spinal anomalies in neonates, and up to 3 to 6 months when the neural tube is still open, only covered by skin and dura, but the bone is not yet ossified. We nicely see the spinal anomalies, meningoceles or lipomas, and all of these can be nicely demonstrated by ultrasound. Also, genital anomalies can be nicely demonstrated by ultrasound. But we should look for, we always say, we find what we already know. So when I examine a case of cloaca, I search for certain pathologies that I know is common or is present in cloaca, as in duplication of the Mullerian system, or aplasia or hypoplasia. All these can be nicely demonstrated by ultrasound. Even the rectal termination can be seen nicely by ultrasound by approaching the perineum. It's well done, especially before colostomy, as the rectum is distended with the meconium. We can see the level of rectal termination. All these can be demonstrated by ultrasound. Going to the conventional imaging and MRI, the comparison between them regarding radiation exposure, as we all know, radiation is high in conventional imaging. However, MRI is zero radiation. It is safe, no radiation exposure, high soft tissue resolution. However, it's all depend on the availability of techniques and the expertise in the institution. The pitfall in conventional radiology, there is always summation of shadows. We are not always see the rectum and vagina and the bladder. As you see the case presented, the mammalian system is not visualized. We can ask ourselves, is it not visualized because of not present or hypoplastic, or is not simply not opacified by the contrast? Here is the role of ultrasound and MRI. MRI is excellent in demonstration of all the aspects of anomalies, and we are in Ain Shams University, we applied rectal anomaly protocol involving spinal sample sequences for demonstration of spinal anomalies, urogenital and mammalian system, not to expose infants or neonates to multiple sessions of imaging. And this is works well for more than 10 to 15 years. Conventional imaging can be well also in can be demonstrating reflux. Reflux can be of course conventional imaging, or reflux is the only modality till now available for demonstration of reflux. In some centers they do contrast enhanced ultrasound to demonstrate reflux, but the contrast ultrasound is not available in all the places.
Thank you. Dr. Ayman.
For Dr. The beautiful photos today that have been shown by Dr. Am has been done, of course, by you. We notice that in MRI, you do not, it's not visualize the rectum in most of these photos, not like this one. So you don't you do like injection of like gel or something inside the rectum, and if the vagina also to have, because if the vagina is collapsed, sometimes the definition of the vagina and its relation to the communal channel, and so it's not good, and also the size. So this are really missed data in most of the cases of MRI, if not trying to distend the vagina or distend the rectum with not, because water will leak, but something like gel and something. What is your feedback? Yeah.
Sometimes you cannot visualize the common channel and even the urethra in MRI. There is no fluid to visualize.
Yes, I agree. The main issue in MRI, it should be done with caution, with thin sections, high resolution images with dedicated coils. And so we can see many MRI images that not comprehensive or not well done. So I can't answer my questions through these poorly done techniques. This one point. The other point, I agree that narrow fistulas and narrow tracts could not be visualized clearly by MRI. But I refer to the thin sections, fat suppressed sequences. This can demonstrate the narrow tracts, but with difficulty, I agree. So that we can go to the level of termination of the rectum, not tracking the fistula. As Dr. Am said, the level of the rectum, there is opposite which vertebra. Again, also the urogenital sinus communication of the urogenital tract in relation to the symphysis pubis. So I agree. In sometimes, despite high resolution techniques, we can see the narrow tracts, but we can replace this finding or this information by termination of the rectal end. In some institutions, they can install gel within the rectum, but I personally don't prefer any invasive maneuvers during the MRI is done under sedation. So I can inject gel or prolong the procedure. The magnet bore is narrow, so I can't manipulate the Foley's caster insertion, the injections. So this can be MRI procedure more difficult. So I prefer to done the MRI during with sense section high resolution and dedicated coil. This is very important. Not every place can perform these sequences. Again, the MRI, a minimal Tesla should be 1.5 Tesla. In lower Tesla machines, the resolution is very poor, despite using sense sections or what's claimed to be high resolution sequences.
So don't have you recommend to do conventional controls?
This refers to this according to the institution, according to the available expertise. Yes.
Can we cordially ask you, because I know you are very much interested in this topic, and you have a newly formed Egyptian Pediatric Radiology Association. Can you try to make a protocol for among all the pediatric radiologists or who are interested in pediatric radiology? Because the quality of MRI we get is quite different from one place to another place in Egypt. Can you work on that to popularize the technique among the pediatric radiologists in your newly formed association? But this is going to help us, please.
Yes, we can. We have also dedicated members. Dr. Tomi, he's interested in rectal imaging and worked with Professor Pina.
I think it's one of recommendation of Congress.
Very nice recommendation.
Okay. Sorry, we don't have enough time. So next, please. Next, please. What is the operation now? This one stage or multi-stage, Professor Ayman?
It depends on the confluence of
You prefer to do PSARP first, then repair of urogenital sinus, or the same reconstruct in the same position?
It depends upon the length of the common channel. If it is short, like Dr. Amr said, type 1, low insertion, so you can do everything in one stage. So suicidal inorecto vaginal urethroplasty. If it is low confluence. If it is high, definitely I prefer to do in 2 stages. If it is borderline intermediate type, it depends upon your own approach. If you can catch everything from the perineum, it's okay. If not, so make it in 2 stages.
Professor Rassam. I think there is no one stage repair for cloaca, unless you don't consider colostomy the first stage. So I think Dr. Muhammad related to definitive repair, because all these cloacas has first stage colostomy. Then we are talking about,
He's considering colostomy as a separate operation.
We talk about definitive surgery.
Yes, so that's because in many years ago, there was some trial to do one-stage repair of cloaca at the neonatal period, and the results was disaster without coverage stoma. This is the one stage, and the results was disaster. This is because there was not enough time to investigate the case and to properly study and properly planning. So let us talk about definitive repair, one stage definitive repair versus staged definitive repair after colostomy at the initial procedure. I think myself planning, I liked that much to do one stage. Do proper planning for and because when you're dealing with cloaca, if you are doing through the posterior sagittal approach, you have a golden chance to have an ample exposure. You can see everything. If you have done just the rectal element and you leave the urogenital rectal by of course it is the easiest part of the procedure. But if you just done this one and lifted the urogenital component till later on, and sometimes you need to go and to disassemble everything, and by that time it's not a virgin field. So I very much against that.
Next, please. Dr. Deveki. Our option for urethra to leave alone, untouched or separation, and doing a new urethra or doing total urogenital mobilization. Anything else?
Okay, again, this depends upon the common channel. Well, once you get the anus away, and then you have a common channel for the urethra and the vagina. The urethra has the paramount importance to be saved with a common channel. So if you want to salvage one, then it's the urethra, because the vagina has other replacement modalities that we can do. So if what's remaining is very short, I will give this all to the urethra, and then we'll do a vaginal replacement with an ileal loop in most instances, yes.
Okay. Next, please. Professor Sam, what is the best replacement for vagina?
What, the same question?
Yeah, what is the best replacement for vagina? What do you prefer?
Okay. Depends also where the first stage was done, I mean the colostomy. Because if you have done, for example, transverse colostomy, then you have an ample length of the, you can take part of the colon and make it as a substitute for the vagina. But if you have like the colostomy was done like other anorectal malformation at the junction between the sigmoid and descending, probably you will not be able to take part of this distal part unless you disassemble the colostomy. Ileum is okay, but the ileum is okay in such scenarios, but the ileum, the blood supply for the ileum, I mean, is not the same quality as the blood supply of the colon. This is number one. And also I feel the ileum is a little bit fragile, it's at least early. But of course it has an advantage also on colon in terms of the amount of mucus they secreted. So there is a pros and cons for choosing a piece of colon or a piece of ileum. But I'm always preferring to have a piece of colon if there is enough colon there during the design of the stoma first. If not, I'm going to take a piece of ileum.
Professor Ayman?
I do agree with Dr. Assam actually, because I have experience with 15 cases of vaginal replacement. I used to use ileum, but most of them are complaining of excessive secretions. And this is very dangerous for them, of course, and it can invite infection because they are afraid of to clean this. So I do agree with Dr. Assam, chronic patch is good for replacement.
Okay. Any experience from panelists or Zafrul about vaginal switch or something else?
Vaginal switch is also an option, but it's a very limited option, and the outcomes are not really as fantastic as it's described. The reproducibility of the technique is not really as expected. It has gained a popularity when it was first introduced, but currently most of practitioners would not go for the vaginal switch. Still, it's always between the ileal replacement or the colonic, or if you did a mobilization and then you get a vaginal stricture, you get the posterior rectal augmentation patch, and it will be an endless controversy whether the ileum or the colon, because each one has its advantages.
I mean, I hope most people would agree that going back on tissues that you already dissected should be avoided at all costs. You should try and do it without going through the same place twice. And if you can deal with the virgin anatomy in one go, albeit that you've had a covering colostomy, maybe a vaginostomy as well to cover that you should try to do that. I think no one would argue either that it's best to have a vagina made out of vagina and not made out of bowel. I mean, pouchitis, as well as the inflammation, stenosis, all kinds of other problems exist with bowel replacements. And the long term is sometimes not known to us. So I think we have to have resistance to doing that as well. It's not an easy option in the long term, I think, for the patient. What we haven't discussed is when there's a bifid vagina or two vaginas, and would people decide at the first operation that they would unify the vagina into a single one, or would they leave it and deal with the septum at a later time? What would people's view about that be?
Usually, they usually resect, or not resect, cutting the septum, making two half of the vagina into one vagina, because again, during the primary repair, the exposure is much better than any time else in the future.
Okay, next please. We want to share a laparoscopic experience in management of cloaca with Dr. Ahmed Faris. Yes. Dr. Ahmed, please. We can, you have a video presentation? Presentation, okay. We can share presentation of Dr. Ahmed.
I just would like to introduce Ahmed Faris. He's a professor of Cairo University and Fayoum. He's one of the best in this minimal invasive surgery in this country, and he has a great interest in laparoscopy in general, but in the field of cloaca in particular.
Thank you for allowing me to speak in this topic. Regarding types of cloaca, from the question that Dr. Abdel Malak asked, I'd like to divide this disease into two diseases. It's an anorectal malformation and urogenital sinus. Anorectal malformation, we consider it as high or low and manage it, in my opinion, I'm sorry, I like to manage the rectum alone by laparoscopy first, and this avoids scarring and making the field scarred for the second repair of urogenital sinus. Next. Many classification, this is the picture from the paper of Dr. Amr. Whatever the type of this, I look only at the rectum at the first repair. Although at the first repair, for all of these types, I would go for laparoscopic anorectoplasty alone. And during laparoscopy, I have the chance to look carefully at 3D imaging or 3D vision by laparoscopy from inside to decide whether there is a neurogenic bladder, whether there is separation anomalies of the Mullerian structures. And after finishing the rectum and having only 2 tubes, it gave me a chance to do the investigation that I like to do for the urogenital sinus, which is the genitography. This investigation, we have only here 2 tubes, and the overlap of the 3rd tube may be more difficult. And also, cystoscopy would be very beneficial in this. After getting the rectum out of the field. In this presentation, also, I would like to concentrate a little bit about the anomalies of the vagina and uterus. Next. We have 3 anomalies of the female ductal system: agenesis of the uterus of the vagina, this difficult syndrome, defect in the vertical fusion of the 2 Mullerian structures, many different classification, and defect in lateral fusion. All these defects may be obstructive or non-obstructive, and this can be assessed properly by endoscopy. Next. This is vaginal agenesis. Treatment of vaginal agenesis is outside the field of cloaca repair, but it can be present. I saw cases of anorectal persistent cloaca, or you see the rectum. Rectum is inserted in the urinary system, and there is no any Mullerian structure. For these cases, they have many operations, mainly for vaginal replacement, like ileum, sigmoid, mycocutaneous flap, skin graft, peritoneum, I don't know what's amnion, absorbable material. Next. But to get a wine that's like a native vagina is to put this Vacchetti procedure. I think he published 1965. He put a catheter from the abdominal side with either open or laparoscopic, then put some bead and do traction on the mucosa at the site of the vagina to elongate the vagina and get like a native vagina in this way. And this, I didn't do this operation, but they have a good result to create a vagina with from the mucosa of the vagina. Next. Vertical fusion. Maybe the vagina developed from two parts. The upper 2/3 from the Mullerian duct, and the lower 1/3 from the cloaca. This is the one that we look at. But maybe at an imperforate hymen or transverse vaginal septum, this is high, maybe low, mid, or low, and sometimes there is a diagonal septum. Next. If we look at lateral fusion, all the anomalies may be present with cloaca, but I think the first one, I saw it many times, complete didelphic uterus, separation of the two uteri, separation of the two cervices, and separation of the two vagina. At one case, I saw the unicornuate uterus, which is the unilateral, the half anomaly of didelphic uterus. If this anomaly is present alone, they would do nothing for this operation, but just to get the vagina outside. Another bicornuate uterus, complete or partial, septate uterus, and septate vagina. Next. This is the posterior sagittal anorectoplasty. For a cloaca that is usually the rectum empties either in urethra or the rectum or the vagina or any longitudinal structure from outside that need a separation from the urogenital system, I prefer to do a laparoscopy for all cases. Laparoscopy only. I don't like excessive scarring that result from this operation. Next. So this is a video. Can you start video? This is a video of a girl with persistent cloaca. She had the colostomy at fit. This is the urogenitography, and this is the endoscopy. At the endoscopy, we saw two vaginas. One rectum, two vagina, and one urethra. At the first step, in all of this, we mark the site of the anus by a muscle stimulator. This is a very important step during the repair. And this is the site of the trocar, one from the umbilicus and one right on left. I'm planning only to repair the rectum and also to identify the anomalies. Here is the ovary. The uterus is complete didelphous uterus that was suspected during endoscopy. Will not do nothing for this. This also have a big urinary bladder. So all my concentration in this very complex case is to get the rectum outside as a first stage. سكيب ما عندكش طب سكيب عشان طويل
سيبه خلينا نشوف التكات.
نرميها بقى.
هو رجع لورا. He is repeating the video again. I'm sorry. خلاص هو مش عارف. لا هو 7 دقايق. So the vision from here is much more clear. It avoids all the complication of posterior sagittal aneurysmoplasty. There are many complications in literature and in my real cases. There is a pull through of the urinary bladder, pull through of the ureters, injuries of both ureters, injuries of pull through of the vagina, pull through of many difficulties because we are working from the blind end from down. But when you look here in 1 minute, you can identify the real 3D anatomy exactly, and you are sure that you are doing the right operation. So dissection is usually combination of blunt and monopolar diathermy in these children. No need to do for harmonic or ligature. And whatever the length or the insertion of the rectum, either in urinary system, urethra, urinary bladder, vagina, all what I do is to go to stick to the rectal wall and finish the connection from the abdominal side. It can be done for high anomalies, for intermediate anomalies, and for low anomalies. So what's the goal here is to have the final picture that at the end is to have a small opening of the anus without any scarring of this, and to deal with the very complex urogenital anomalies at a second stage. You want to ask?
In this case, what was the length of the urethra and the common channel?
Urethra and I'm not concerned at all about the urethra or the common channel. How to repair the vagina after this? This is the second operation. If the vagina, we should do a genitography and cystoscopy again in the next step to qualify. If the length of the vagina is enough to gap the defect between the future side of the vagina and the insertion with the urinary system, I will do vaginal pull through. I don't like urogenital mobilization. Urogenital mobilization, we did a lot of these cases and ended up with many problems, recurrences, stricture, urine incontinence. So I don't like partial or complete urogenital mobilization. Even partial, even cases of partial urogenital mobilization have degrees of urine incontinence. So my preferred is to do a vaginal pull through for the vagina.
So what if you have like
if the length of the vagina is not enough to gap the length, so we have to bridge this gap by either colon or small intestinal loops. Yes.
And what if you have a really short urethra that wouldn't reach down? What would you do?
Urethra is not short.
What if you have it short, like if you have less than 1.5 centimeters?
The urogenital sinus that's coming out is the urethra.
Separation, right?
Urogenital sinus that comes out, it is the urethra. You don't touch, you just separate the two tubes, the rectum first, the vagina, and you don't not touch, you can use the urogenital sinus as a urethra. The common channel. Sorry, here this is only for rectal repair. So we follow the rectum till it's tapered to have the enough length of the colon to reach the outside. Also to preserve what is written in literature, the terminal end of the rectal fistula is an internal end sphincter, and we try to preserve this. When we go down, we just get the connection. Here the connection is between the rectum and the urethra. It is a recto-urethral fistula. And one notice that the vagina, two hemivaginas are inserted above the rectum.
You mean the communication between the rectum and the urethra or the common channel?
The common channel, you can, I call it the urethra.
You also separate the vagina by the porosity?
Not at this stage. لا مش هنا. I will not separate the vagina here.
You separate by the porosity?
Yes. I don't do the two operations at the same time because no. I don't do this because when we go to the perineum, I want to put the rectum inside the proper sphincter, and after finishing that, when I try to do vaginal pull through at the same time, it destructs the sphincters.
Ahmed, I know you are perfect laparoscopist. It's very wonderful demonstration for the fistula. You're going with it to the end, but I need your wording for sometimes in the high configurations the ureteric end is abnormal. It's not in the normal trigone. All are going down, and if not, you are very good in laparoscopy. It's not that safe, Doctor. I hear Doctor. Saying that everything under vision, but sometimes it's everything is going in the high types, especially the ureteric.
Yes, I agree with you, but in posterior sagittal, you also don't see that there is a published cases of ureteric pull through and a published cases of bilateral ureteric injuries.
Yes, whatever.
So
you have to have proper planning. It's better than to go to the operation and to discover what.
No. We investigate. So we anesthetize the patient 2 times. The first time to do a genitography, or what you call distal lupogram with genitography with endoscopy at one stage, and we finish and we make a plan to do what we are going to do for this each case.
I see a lot of patients, excellent patients you have did, but I'm just warning here. It's not that easy, except in sometimes the ureteric orifice is abnormal. And especially
I will discover this during endoscopy.
But it's very variable. You can discover the normal, but sometimes the variation. It's better to have an idea and match this anomaly with your skills before.
So at the end, I would like to transform the patient with cloaca to this patient and to deal later on with urogenital sinus.
Dr. Ahmed, just make it a little bit clear that doesn't mean that you don't have a long skin incision, long skin incision at the perineum, that there has not been a lot of dissection at the pelvis, and that the piece of urethra from that confluence to the bladder.
Exactly. From the confluence to the bladder, if I'm planning to do a urogenital pull through, but I'm against urogenital.
It's exactly the very basic about the erectile malformations, that they are shades of gray.
Yes.
They are not always white and black, but they are shades of gray. So in the very high insertion of the rectum, yes, this is the minimal invasive surgery and laparoscopy is straightforward, and you will not find any argument about that because it goes really very fantastic. For in the very low confluence, then we will keep on the argument for quite long, because it depends upon the skills of the section and whether it's easiest to do all the repair when it's still a virgin tissue, or would you like to do it staged and you get into more adhesions and more possible affection of the sphincter, which is already hindered?
Go ahead.
Thank you, Dr. Ahmed.
أنا بس عايز
ممكن نعمل presentation
دكتور
تاني؟
محمد يعني
اتفضل.
أنا هقولها بالعربي مش هقدر أقولها بالإنجليزي يعني بسأل واحد على القصة ديت اللي كان بقول لك احنا هنعمل الانوريكتال بعد كده يا اما انا اكون مت يا اما العيان مات لما نيجي نعمل
نرجع next please. Next. We did. Next. It's about complication, post-operative complication. Most common complication after cloaca repair from your experience, Dr. Assam, and how to manage.
I think the most common complications. Let me talk about outcome rather than complication per se. The problems we face in cloaca patient is the urinary, and because many of this you do a nice operation, and then the problem starting the patient does not make it urate normally, and she has a dribbling, and she has distended bladder, and even trying to do CIC from the urethra is not decompressing very nice. Sometimes you do suprapubic cystostomy, and also we have some problem with micturition. This is the most problematic problems in dealing with cloaca, and I think the cause of this patient to long-term follow-up is the end-stage renal failure. This is the most because the patient they don't in this cloaca patient something really strange. They do not have an issue with anorectal incontinence. They have sometimes some sort of, they can keep 2-3 days without defecation, doing some enema, they clean, and that's it, and they're very happy. They don't have a problem with soiling, repeated soiling, but the main issue in patient with cloaca, and also the genital problem, they don't come after 20 years or become the patient is sexually active. The main burning problem is the urinary system, and their bladder is not emptying their bladder.
This good observation also, this no problem of cases.
They don't complain of fecal incontinence. They don't.
Next, please. We move fast about UTI risk post-operative. What is the causes and how to avoid? Dr. Peter.
Well, of course, it's down to the patency of the urethra. It's down to the emptying of the bladder. And if the bladder doesn't empty, we know, and if there's vesicular reflux, we know that's a potent combination to cause upper tract damage and ongoing issues. So I think you just got to keep an eye on bladder emptying. With follow-up ultrasound scans, think about intermittent catheterization if it's not emptying well, prophylactic antibiotics, and I agree with what's been said that the failure of the urethra stroke urogenital side of this is often due to infection, and being careful about that in the immediate post-operative period is quite important too.
I think we have causes from original pathology, original associated anomaly like reflux or ectopic ureter or whatever, or neurogenic bladder, or spinal deformity. It is one of playing a major role in reflux. And we have causes due to the operation. Especially when we operate with urogenital mobilization, we bring the bladder neck and the below sphincter or perfect brim. This one also a complication, urethral stricture or recurrent urethrovaginal fistula. Many causes post-operative cause UTI. Dr. Nancy, from your experience, how can we manage with cases post-operative? This differ.
As the professor said, the most two annoying problem post-operative in these patients are the risk of on the upper tract from the recurrent UTIs is the most annoying complaint for the nephrologist, that the patient is feverish, it's febrile UTI, and every attack we are losing some part of the kidney or some nephrons of the kidney. So it is the most alarming complaint. The incontinence is annoying the patient and affecting his quality of life. But what is affecting the life of or threatening his life is the recurrent UTIs taking us rapidly to the end stage. And I think in complicated anomalies, to prevent UTI, it can't be achieved only by the prophylactic antibiotic. We have to solve the anatomical risk for UTI. And that's why we are always discussing these patients have recurrent UTI, we have to solve the problem. We shouldn't depend only on the prophylactic antibiotics and waiting for spontaneous resolution. The second point about the incontinence, I think the urologists have to comment better here. Again, to avoid, and we don't have to forget the role of the bowel management in preventing the UTI, the treatment of the constipation. It improves the condition a lot, so we don't have to ignore this.
Next, please. As Dr. Assam said, when life seems difficult, we pray to something to happen, either to surgeon or to patient. Next, please. We need how it works, our long-term follow-up. Next, please. Next, please. In long-term follow-up, we aim for urinary control, power control, and sexual life. Next, please. Dr. Tibiki, what about long-term follow-up?
For the gynecological outcome, usually this is really overlooked until they reach the puberty and they seek marriage and sexual activities. And in the cases that we have seen over the last couple of decades, most of them are suffering of narrow introitus. So this is usually easily solved with Michelix-Heinz repair. And some would have dyspareunia because of the strictured vagina. And usually this needs either augmentation with the rectal flap. And few of them have been overlooked for the vagina all of its length. And usually by the age of puberty, it's almost impractical to try to reconstruct that. You have to replace it with the graft, and usually at that case you get what's accessible more, whether the ileal or the sigmoid.
Okay, Dr. Peter, about long-term follow-up in patient with cloaca. From your experience, what about long-term follow-up in patient of cloaca as a urological outcome?
I think, like I already alluded, we have a cloacal service, and that has nurse specialists, and it involves nephrologists and quite an intensive follow-up program. So I think it's important, if you group these patients, to have a proper follow-up protocol for them to establish the long term. I think some of the things in the long term are not known, but complicated patients are complicated. They have big operations. They have risk of all of these things, urinary tract infections, and the simple operations. The reason that we love doing these things are simple and they work out well. And I mean, what do you think about the urinary outcomes? Are you happy with the urinary outcomes? I mean, determining which is iatrogenic and which is the original anomaly, I think, is difficult in the long term, isn't it?
Any comment for
it's a big
Dr.
question to ask.
For us,
in a case like this, measure many times because you will get one blank.
Yes.
as all professors said, the urinary system complications is the main issue regarding the patient morbidity and mortality. However, gynecological issues are also important. So from our cases, we recommend to start the screening for gynecological alterations as early as possible, starting from the prior puberty, about 10 to 11th year, to start searching for any associated anomalies, which is especially obstruction. Obstruction may not be evident in early stages in infancy, however, it can present later, and we should not wait until complications happen. We should search for it by screening, as we saw cases presented with obstructed mammalian system, large pelvic cysts, hydrosalpinx or pyosalpinx, and all these complications should be monitored early or screened early, not waiting for the proper problem to occur.
I think lots of these issues crystallize themselves in the patient that's got marginal renal function and marginal continence over a long period of time, maybe throughout the whole of childhood, and then goes towards end-stage renal failure, and then starts thinking about a transplant. And then you start having conversations about what a safe bladder would be, and as a teenager, they suddenly want to be dry. And I think in that situation, then your cystoplasty comes into play for a significant number of these patients, and you're going to make them a safe bladder, give them a catheterizable conduit, use the residual UG sinus or whatever is there in the perineum as the vagina, with a reconstructed bladder above, emptied by a Mitrofanoff. Okay. And then that's a place for their transplant kidney to go. So I think in a way the marginal patients that are slightly incontinent or not particularly continent maybe don't have a great cosmetic outcome, maybe have a marginal vaginal reconstruction, and maybe have poor renal function. These are difficult to manage until they reach that end stage when everything becomes a lot clearer. It's slightly perverse, isn't it? But when you have to do a definitive reconstruction, you can often fix all of these things in one go, albeit that they'll end up with a transplant and a reconstructed bladder.
Yeah, I think just to complete the issue of gynecological, because we have to address fertility. And it might be something like luxurious if we are talking about fertility in a patient who is born with cloaca. But still, there is several issues with fertility in these cases, especially if cystoplasty and Mitrofanoff has been done, if pregnancy occurred, how the uterus will start to enlarge with pregnancy, how it looks like, how it affects these. This is a very, very complex issue. Needs specialized obstetric gynae working with urologists and pediatric surgeons, because this is a very complex issue. And also, one of the things that we have when you consult the patients and the parents, they have to know the huge series of cases in which there was the vaginal replacement with bowel. I would say the group of patients with the series was Alberto Pena, just presented by Bishop, Dr. Andrea Bishop. They said they don't have single case of pregnancy, successful pregnancy in a cloaca patient treated by esophageal by vaginal replacement by a piece of bowel. This actually was a little bit shocking for me. But of course, Herdy Hendren had, they have a long, also the second, the biggest series. They had some pregnancy in these cases, but the series of Alberto Pena, as I said, they have fertility in cases of the vagina the native vagina has been used, but none with the use of vaginal conduit or vaginal graft by bowel.
Thank you, Dr. Assam. And next, please. But in the end of our session, we happy to announce we started a program for perfect reconstruction, correct, and perfect reconstruction surgery in Nile of Hope, and we are ready to, and we honored to be in cooperation with another university to to establish a multi-center study and to develop specialized group for treatment of such a complicated case. Next, please. Professor Ayman, please take home message.
As I said to you minutes ago, measure a lot to cut once.
Yeah.
This is a complicated case. A lot of complexes in one package.
Okay.
So you have to investigate properly. You have to deal with, as you see, a lot of ways of management. Dr. Ahmed Faris taking one line, Dr. Assam another line, me another line, and so on. So just prepare the patient in the proper way, do initial management properly, so investigate well, and then do your own decision or manage by your own decision in the patient, and try to decrease the complications and make the outcome the much better that you can.
Thank you. Next, please. Thank you for all. Sorry for delay.
البيدياتريك اورثوبيديك فالسيشن دي هنتكلم we'll talk about the common pediatric orthopedics. أنا بروفيسور أمين عبد الرازق بروفيسور بيدياتريك اورثوبيديك ألكسندر يونيفرسيتي. يسعدني ويشرفني إن معايا أستاذنا الأستاذ الدكتور حازم الطيبي أستاذ جراحة العظام الأطفال من طب جامعة المنوفية. we'll talk about the pediatric orthopedic today. بروفيسور محمد عبد العظيم كان عايز ياخد اورثوبيديك زمان بس ما خد جراحة أطفال، صح يا محمد؟ كان قبل. طيب اتفضل بس.
أستاذ أمين هيتكلم على الأورثوبيديك بيدياتريك أورثوبيدكس.
السلام عليكم. هو احنا هنتكلم عن البيدياتريك اورثوبيديك بس طبعا هنتكلم from the pediatric point of view not the orthopedic point of view، لان طبعا التارجت بتاعنا هو البيدياتريشنز والبيدياتريك سيرجن. فهنحاول نقول ايه البيدياتريك اورثوبيديك بروبلمز اللي احنا بنقابلها او حضراتكم بتقابلوها كبيدياتريك. والبتاع ده شغال؟ Okay. Regarding the common pediatric orthopedic problems, we will classify for simplicity يعني ايه pediatric orthopedic problems إلى stages according to the age of the patient. يعني في النيونيتس اللي هو لسه newly born ايه البروبلم اللي ممكن نشوفها فيه؟ ايه الحاجات اللي ممكن نشوفها فيه؟ اللي هي الحاجات اللي واحنا بنعمل سكريننج للطفل اللي لسه مولود. تمام؟ الحضور ايه؟ بيدياتريك ولا بيدياتريشن؟ حضراتكم كم واحد بيدياتريك؟ ده ايه؟ انستيزيا؟ طيب اوكي. طيب اليونيتس بنبص على اول حاجه بتهمنا اللي هو الدي دي اتش اللي هو الهيب ديسلوكيشن. يبقى نمبر 1 هيب ديسلوكيشن، وبعدين وات ار ذا كومن كونجينيتال انوماليز. الكونجينيتال انوماليز اهمهم الكلاب فوت وحاجه اسمها ميتاتارسس ادكتس، وبعدين اللاست اخر حاجه اللي هي البيرف انجريز. دي الحاجات اللي احنا بنعمل سكريننج للطفل لسه مولود. لو انت كدكتور بلغوه جوه الطفل لسه مولود هتبص على ايه؟ هتبص على دول، هم دول اللي يهمنا انك تشوفهم. اول حاجه الدي دي اتش، ايه الهيب ديسلوكيشن او كونجينيتال هيب ديسلوكيشن؟ congenital hip dislocation this is common in female. يبقى نمرة واحد كريسك فاكتور لو هي female common about 80% of the cases common in female. نمرة اثنين commonly is unilateral and affecting the left hip mostly. يبقى common in female and left hip mostly. في some risk factors many risk factors we have to search for عشان نقول ان ده ممكن يبقى DDH او hip dislocation. كل اللي انا مطلوب مني ان انا to diagnose DDH early. يبقى how to diagnose DDH early لان المانجمنت early DDH يفرق كتير جدا على الليت مانجمنت اوف DDH. فالريسك فاكتورز هي الليجامنتس هايبرنكستي، بريتش بريزنتيشن، اوليجوهيدرامنوس and postnatal neonatal positioning. بعض البوزيشننج مش عندنا هنا في مصر ممكن تكون هي predisposing factor for DDH. يبقى these are risk factors of DDH. يبقى female with these risk factors